Is being recorded.
The floor is yours.
Thank you. Good afternoon, everyone, and thank you for joining this important informational meeting on the practice of white bagging. My name is Maria Serpa, chairperson of this committee. During this meeting today, we will receive a number of presentations from various stakeholders on the practice of white bagging. Before we convene, some general announcements. This meeting is being conducted consistent with the provisions of Governor Gavin Newsom's Executive Order N-2920. Participants watching the webcast will only be able to observe the meeting. Anyone interested in participating in the meeting must join the WebEx meeting information and instructions posted on our website. I would like to ask staff moderating our meeting to provide general instructions on how to participate at appropriate times throughout the meeting. Moderator?
Thank you. This is the moderator. Before we get started, I would just like to remind board members and staff who are not speaking, as well as presenters when you're promoted to panelists, when you're not speaking, to please mute your microphones. If I do detect background noises during the meeting as a result of unmuted microphones that are causing a disruption, I will either provide a brief friendly reminder or simply mute your microphone for you. There are members of the public in the audience, and meeting minutes are being taken. So we do ask that board members, staff, and presenters please identify yourselves before speaking. To facilitate public comment today, we will be utilizing the WebEx question and answer feature. When the committee chair reaches a point in the agenda at which public comment is appropriate, public comment will be requested, and at the direction, I will turn on and announce the opening of our Q&A feature. Members of the public can indicate they would like to make a comment by clicking on a Q&A icon with a question mark within a square located at the bottom right-hand corner of your screen. That's the typical location anyway. The instructions will be shared on the screen at the time for your reference, and we will be asking that in the text field you simply type, "I would like to make a comment," and then send that to all panelists. We will be taking comments in the order that they are received. I will call on each member of the public that has requested and unmute their microphone, announce the time limit to the public comment, and then provide a 10-second warning, and then at the conclusion of your time, I will be muting your microphone. And please know that the Q&A feature is only being used as a means for members of the public to represent.
We've all been there. I have a dog too. She'll be back in a moment.
My apologies. Heaven forbid a delivery arrive. Oh, okay. So again, please note that the Q&A feature is being used only as a means for the members of the public to represent that they would like to make a verbal comment. And if any attendees use a profane name, you will not be called upon, and your microphone will be immediately muted for use of any profane language. And again, if you do not have a microphone and you are having audio issues, you can click on the audio and video at the top of your screen and select switch audio, and that will give you some further instructions on how you can link your cell phone to your computer if you are having some audio issues. And with that, I will turn the meeting back over to Chair Serpa. Thank you.
Thank you. Now we'll take a roll call to establish a quorum. Members, I will call your name and let us know that you're here. Greg Lippy.
Here.
Jig Patel.
Here.
Ricardo Sanchez.
Here.
Debbie Veal.
Here.
Albert Wong.
Here.
Great, thank you. With a quorum being established, the committee will now entertain any public comments for items not on the agenda. To facilitate this portion of the meeting, the moderator will open up the phone line for individuals to provide an opportunity to provide public comment for items not on the agenda. Individuals will be provided 2 minutes to provide such comments. You're not required to identify yourself, but may do so. And as we open the lines, I'd like to remind everyone in the committee, we cannot take action on these items or discuss them only to decide whether to place them on a future agenda item, a future agenda date. Moderator, we're ready for a public comment.
This is the moderator. We have opened the Q&A panel for requests for public comment. If you'd like to make a comment, please click on the Q&A icon on your screen, type "I would like to make a comment" into the text field, and then submit that to all panelists. We will now pause for a brief moment to allow time for submission. Our first request for comment comes from an individual identified as Vu Fan. Vu, I have unmuted your microphone and you will have 2 minutes.
Okay. Can you hear me okay?
Yes, we can.
Okay. So I have a 4-man oncology practice at Los Alamitos in Long Beach. I wanted to make some comments about the white bagging. Some of the issues my staff have ran into is basically...
Excuse me, is it Mr. or Dr. Fan?
Yes.
We haven't started the white bagging discussion yet. This is for items not on the agenda, so anything other than white bagging.
Oh, I'm sorry. I can wait.
Okay, thank you. And I'm sorry, is it Dr. Fan or Mr. Fan? I apologize.
That's fine.
Thank you. I think we have someone with a lot of background noise. That they're buying something that's blowing or maybe in their car. Thank you, moderator. Are there any other public comments?
Not seeing any further requests for comment at this time.
Great, thank you. Now we will receive a number of presentations from various stakeholders on the practice of white bagging. At the onset, I think it's important to note that we have publicized this informational meeting and have reached out to identified stakeholders to participate with the goal of receiving various perspectives on this practice to ensure our education on the matter is comprehensive. I would like to thank all the presenters for their time, as well as those stakeholders who provided written comments. Written comments are posted on the board's website. Before we hear from our first presenter, I wanted to provide a little bit of background on the practice. Much of the information I will be sharing is included in the information published by the National Association of Boards of Pharmacy's report on this practice. The link to this report was included in the agenda and in our announcements regarding this meeting. As included in the report, white bagging refers to the distribution of patient-specific medications from a pharmacy, typically a specialty pharmacy, to a physician's office, hospital, or clinic for administration. It is often used in oncology practices to obtain costly, injectable, and infusible medications that are distributed by specialty pharmacies and may not be available in all non-specialty pharmacies. Today at our meeting, we will focus on white bagging, but I think it's important to note that there is another practice that's called brown bagging. This refers to dispensing a medication for a pharmacy directly to dispensing a medication for a pharmacy, but directly to the patient first. The patient is then the one who transports the medication to the physician's office or administration site. It appears that the practice of white bagging has become more frequent as payers more robustly require the practice as a means to reduce medication costs. The NABP report details some of the benefits to the practice of white bagging, including the potential for greater opportunity for pharmacists to use their expertise to improve patient outcomes, as well as the opportunity for physicians to reduce costs associated with purchasing and stocking expensive medications. From the payer's perspective, benefits include cost savings through negotiated dispensing rates and increased transparency. Safety concerns have also been identified, including special handling that is required for many of these medications, which can pose safety, operational, and unexpected financial burdens. Additional challenges may arise as specialty pharmacies may not have access to patient medical records, as well as the unpaid expenses resulting from the coordination, storage, and handling of patients' medications until the drug is administered. Further, the practice could present some challenges in the instance where there is a change in dose or strength, or a transition to a different class of medication, which is common. Further, potential delays in patient care resulting from receiving the original medications can also occur. As included in the NABP report, it may be incumbent on the board to determine who is accountable for verifying the authenticity and integrity of the drugs before administration, as well as who would be responsible when a delay in therapy occurs. This may be questions we need to answer, but I suggest today that we only consider these and other issues that we identify at this point. Only after we have completed our education on this important issue should we go on to decide what further steps are needed or required. Following each presentation, I will ask members of the committee if they have any questions for the presenters. Following all the presentations, so after all their presentations are done, I will open the discussion for public comment in total. We will have the moderator allowed 3 minutes per each person public comment and provide flexibility to further dialogue between the commenter and the members as appropriate. Members, are there any comments before we begin with the first presentation? Okay, hearing none. So just to
Maria?
repeat. Yes,
Actually,
Debbie?
I just have a question and a comment. I appreciate a lot of the presenters provided us with their presentations ahead of time. And there is quite a few that talk about things other than white bagging. So I was just wondering if Ms. Smiley could tell us today. I think we've agendized only white bagging. Can we talk about, I've also seen the words brown bagging and clear bagging.
I think, hi Debbie, this is Eileen. Because we only put on the agenda white bagging, I think we should limit the discussion to that at this point. I think most of the presentations, talk about brown bagging. I guess one also talked about clear bagging, but because the agenda was really only on white bagging, I think we should narrow the discussion to that.
Or should we encourage the presenters to also keep their comments just to white bagging?
We can if the committee really is only doing an informational meeting now on white bagging. I understand some of the issues cross over, but to the extent the presenters can concentrate on white bagging as we put on the agenda, that would be helpful.
And then Maria, the other thing I was going to suggest that we ask all the presenters is to please, we definitely want to know about the problems, because I think that's what we've heard, and I think that's why you as the committee chair, put this meeting together. But I'm hoping that folks will also provide us with solutions that can be actually enacted by the Board of Pharmacy. So not solutions that, are not Board of Pharmacy purview, but solutions and what they're hoping the Board of Pharmacy, what they're hoping that the Board of Pharmacy can do to solve whatever issue that they're presenting. Thank you.
Thank you. That's a good point. We certainly are looking for any comments, especially things or issues that can be addressed specifically by the board. I'm not sure if that was Ms. Marks or Ms. Smiley who spoke, but I have a question.
Sure, this is Eileen.
Oh, Ms. Smiley, Eileen, during the presentations, is it appropriate for the presenters to briefly mention brown bagging or clear bagging only as it relates to white bagging, or not at all?
I think that's okay to the extent they raise similar issues. I know the brown bagging raises some other issues as well, but I think they can talk about it, but we don't want to go off too much on a discussion of brown bagging or clear bagging when we put just white bagging on the agenda.
Okay. And will you assist us in interjecting if you think we're going too far?
Sure,
Okay.
I can do that.
Thank you. Okay, before we begin, I understand that during the setup of this meeting that there were several comments that there were going to be additional speakers at the, there are going to be additional speakers during the group presentations. and such. I don't have those names necessarily as part of my introduction. So if you would please introduce yourself, identify yourself for the record before you speak, that would be helpful for all of us. Okay, I think we're ready to go. So let's start with our first speaker, which is Sarah Ream, presenting on behalf of the California Department of Managed Healthcare. Ms. Ream is Chief Counsel for the Department of Managed Healthcare. And I believe she has a PowerPoint presentation for us.
I do. Good afternoon. Again, this is Sarah Ream. I am the Chief Counsel for the California Department of Managed Healthcare. I really appreciate the opportunity to come and speak before you this afternoon to tell you a little bit about what our department does and doesn't do, and the extent to which we regulate pharmacy benefits for enrollees in California. Next slide, please. So I will be providing just a brief overview of what our department does and an overview as well of what the DMHC, how the DMHC regulates pharmacy benefits. I will not be talking specifically at any great length about white bagging because, as I'll explain in more detail momentarily, we really don't get into the relationships between providers and plans unless that relationship poses some type of potential danger or harm to enrollees, potentially endangers the ability of the provider to provide medically necessary services to the enrollees, or if it otherwise violates the provisions of our body of law. Next slide, please. So the DMHC is primarily a consumer protective department. We protect the consumer rights of healthcare enrollees in California, and we work to ensure a stable healthcare delivery system. Next slide, please. We do this by, well, let me back up. I said we protect enrollees. We protect more than 26 million enrollees, specifically in California. And we do this by regulating licensed health plans in California via the body of law that we're charged with enforcing, which is the Knox-Keene Healthcare Service Plan Act of 1975, and it's the regulations thereunder. And you can probably, now I'm receiving a delivery, so my dog is barking. It's always perfect timing. Next slide, please. We regulate a full service and specialized health plans. So full service plans are, they offer the medical surgical benefits. They're typically what someone would think of when they think of a healthcare service plan. We also regulate specialized healthcare service plans, which provide specialized services, for example, dental services, vision coverage, chiropractic coverage, EAP, Employee Assistance Program coverage, those sorts of things. So we cover a variety of types of different health plans and different types of products. We also regulate the commercial and Medi-Cal managed care plans. In total, the DMHC touches the lives or regulates the products for approximately 96% of the commercial and Medi-Cal managed care lives in California. So we have we're the primary regulator of health plan products in California. We also regulate Medicare Advantage plans, but those, we have limited jurisdiction over those plans because they're primarily regulated by the federal government. Our regulation over those plans consists of ensuring that they have adequate financial reserves, adequate finances to provide the services they are promising they'll provide, and also they have the administrative capacity to deliver those services. One point I want to make sure that I hit hard here is that we also operate a help center. We have 24/7 live people answering the phones, responding to emails for complaints, concerns that consumers have regarding their healthcare benefits and receiving those healthcare benefits. We have a very, very robust consumer protection system in place with our help center that really does help thousands of enrollees every year. So I just wanted to make sure that we have that phone number here. You can also, down at the bottom of the slides, is our website, healthhelp.ca.gov, where an enrollee can go to receive help. Additionally, we have a provider complaint unit that can provide assistance to providers who are encountering difficulties or have questions about receiving reimbursement from the enrollee's health plan. Next slide, please. So I think it's important, before I move into our regulation of pharmacy benefits, to just give a quick overview of what the department does not do. So I mentioned that we regulate the majority of health care coverage in California, but California has a bit of a unique situation in that we have two health coverage regulators. We have the Department of Insurance as well. So our department, while we work closely and collaboratively with the Department of Insurance, there are a small number of products, health insurance products in California, that are regulated by the Department of Insurance. So we do not obviously regulate those. We also don't regulate self-insured employers who offer benefits to their employees, healthcare benefits. Those products are regulated by the federal government. We don't regulate providers, at least we do indirectly, in that there are some types of providers who want to pay claims. So they delegate services, they pay claims to other providers. We have some primarily financial oversight with respect to those providers, but by and large, the department does not regulate hospitals, pharmacies, doctors' offices, medical groups. Those are not within our purview. We also don't require plans to contract with any particular providers. Now, with that said, we do require health plans to have contracts in place with enough providers to provide timely and geographically reasonable services to their enrollees. So health plans have to demonstrate to us that they have contracted with enough doctors, pharmacies, and hospitals and other types of providers to ensure that the enrollees who purchase coverage or who are covered by the health plan have adequate access to all the medical care they need. But we don't dictate to the health plan ABC that they must contract with provider XYZ. That is left to the plans and the providers to negotiate on their own. And then finally, we don't set provider reimbursement rates. Again, that is something that is within the purview of the negotiations of the plans and the providers. Next slide, please. So I've talked about what the department does and doesn't do. Want to touch base now on the reason why everyone's here, which is the prescription drugs and white bagging. Most full-service plans in California, most full-service plans that are regulated by the department, require health plans to cover medically necessary prescription drugs. This coverage is allowed to have cost sharing associated with the prescriptions, up to $250 for a 30-day supply in most instances. If someone is in a high deductible bronze plan, so it's a high deductible plan that has an actuarial value of approximately 60%. In those instances, the enrollee receiving services may have to meet their deductible before they can receive their full coverage for the pharmaceuticals. They may also have to pay a bit more out of pocket, typically about up to $500 for a 30-day supply. But for the majority of products, it's a $250 deductible. We also receive and report on information regarding healthcare costs associated with prescription drugs. There was a law enacted some years ago. It's SB, or Senate Bill 17. It was enacted in the 2017-2018 legislative session. That requires health plans to report to the department a host of information, including the top 25 most prescribed drugs, the top 25 most expensive drugs, and the department takes that information and analyzes it, puts it out in a public report. We also look at the extent to which prescription drug costs paid by plans, how that impacts premiums. So as you can see from my slide here, from between 2017 and 2019, plans, the amount that they paid in prescription drug costs increased by $1 billion. Prescription drug costs also accounted for 2.8% of the total health plan premiums, and that there's a mistake on my slide, I apologize. That should be in 2019, not 2017. So obviously, cost is costs and expenditures on prescription drugs is something that we track and that clearly makes up a large amount of the premium dollars that are spent. Next slide, please. So finally, the department, as I said, we do not have authority to prohibit or regulate white bagging or brown bagging or clear bagging. I've never heard of clear bagging. I'm not sure what that one is, but we don't have the direct authority to prohibit this, to allow it. Our body of law is silent as to this type of a practice. However, if the practice were to pose a risk of harm to enrollees or impact an enrollee's ability to receive medically necessary care in a timely fashion, that's when our department, using our body of law, the Knox-Keene Act, that's when we would have, we would step in and say, wait a second, there cannot be practices occurring that are harming enrollees, harming those enrollees' ability to receive care. That is true not just for this issue of white bagging, but for any type of issue that might come up in the healthcare arena. If it looks like it will harm or potentially harm an enrollee or the enrollee's ability to receive care, then our department would act to prevent that harm. So with that, brings me to the end of my presentation. I'm happy to take questions or provide more information to the extent I can.
Members, do you have any questions? Thank you, Ms. Ream. I really appreciate your information.
Thank you.
Our next presentation is from the California Association of Health Plans, and today we're going to hear from Charles Bocci.
Good afternoon. My name is Charles Bocci. I'm with the California Association of Health Plans. I'm the President and Chief Executive Officer. We are a statewide trade association that represents 45 full-service healthcare plans who provide coverage to more than 26 million Californians. And Sarah is our regulator, and the DMHC regulates all of my member plans. Most of our members provide coverage through the individual and group markets, and many of them partner with the state by participating in government programs providing health coverage to children, adults, and seniors, the Medi-Cal program. And we also contract in the Medicare space as well. There's a lot of diversity among California's health plans. We provide comprehensive coverage through the HMO model, the PPO model, commercial health plans, public plans, which include county organized health systems and local initiatives. We have regional plans, and of course, some large fully integrated health systems where the plan and the provider group are all integrated together. I'd just like to thank the subcommittee for the opportunity to speak today on the issue of important but expensive medications and the efforts that health plans and healthcare systems are taking to keep healthcare affordable. I was asked to join you today and share the perspective of plans and insurers on this issue, which might be somewhat different from other stakeholders on today's call. One of the things that we do at CAP is we really focus on the affordability of our healthcare coverage. Healthcare costs and healthcare cost increases are a problem for everyone. They're a problem for our nation, where many question whether the rising healthcare costs are sustainable for our entire country. But this also can be an affordability issue all the way down to the individual who's purchasing coverage with their paychecks. And study after study shows that the ability of individuals to purchase coverage is directly related to the cost of that coverage. The higher premiums go, the more people drop coverage. That's why the ACA provided federal subsidies for many people across this country to be able to afford their monthly premium for their health care. Employers who hire us to provide coverage to their employees, including labor trusts, are constantly pressuring us to find ways to lower healthcare costs and to make healthcare more affordable for their budgets. And of course, government payers are very focused on limiting taxpayer expenses for our healthcare costs as well too. So the vast majority of health plan spending in California goes to pay for medical services like hospitals, doctor visits, prescription drugs, lab tests, x-rays, medical supplies and equipment. And in 2019, health plans spent more than $172 billion in California. 86 cents of every dollar collected in premiums or reimbursements was spent in the same calendar year on medical care. Now, health plan premiums directly reflect the cost of goods and services. And when the price of those services go up, premiums increase. In California, as Sarah outlined, health plans are tightly regulated, and we must comply with extensive transparency requirements for how we set our premiums, our premium prices, and how we spend people's hard-earned healthcare dollars. And because of that transparency, we know that in 2019, health plans picked up 92% of the cost of the 25 most costly prescription drugs in our state. Overall, spending $19.6 billion on prescription drug costs in 2019. And unfortunately, prescription drug cost spending growth is projected to increase by CMS by over 5% in the next 2 years, making the situation only worse. Inpatient drug costs are substantial, and plans have to cover the cost of the medication, as well as the cost of administering the medication, and other charges related to a visit to an office or a facility. So as a result, drugs that are administered to the patient by a provider at a site other than the patient's home, so these are clinics, hospitals, infusion sites, physicians' offices, can at times cost significantly more. That's because there's other charges around the visit, but it also can be a result of what we see as a significant markup for the cost of the drugs being acquired by the facility. These are markups above and beyond the acquisition cost. And while we understand that those markups are a source of revenue for the facility, we believe that some of these drugs can be purchased much more affordably while still being administered in a safe and efficacious manner. As health plan benefits have evolved over the past decade, some plans and insurers, in response to the high costs of these drugs at the facilities, have moved the drug portion of these inpatient costs to the drug portion of the plan. So they've moved it from the medical portion of the plan to the drug portion of the plan. And that allows the plans that choose to do that to negotiate directly with specialty pharmacies to acquire the drugs at the actual cost, plus a minor dispensing fee. So this strategy can be a substantial reduction in costs, in many cases, thousands of dollars per dose or per treatment. And this practice is called white bagging and is the subject of our discussion here today. Plans and insurers believe that this practice has been done safely and can be done safely. This isn't a brand new practice. We believe that a prescription sent via this white bagging modality has or should have the same safety profile as a drug shipped by a wholesaler or distributor to the facility itself. It's really the same thing. It's just purchased as a different point of purchase and a different purchase price. These products, according to the pharmacy directors at the plans, should in most cases mimic the shipping conditions of the manufacturer or wholesaler, to keep the chain of custody intact and to protect the patient. I'm not sure ultimately what this committee is going to be asked to do on this topic, but we do know that from my colleagues across the country that there is a coordinated effort at pharmacy boards in several states already, and I'm sure it will continue throughout the year, by some stakeholders to either limit or prevent the practice of white bagging. I'll let them speak for their reasons for it. But I just think it's important that the board, in considering any action, know that taking a stand that limits or prevents the use of this mechanism to purchase and dispense the drugs, is not going to change the coverage for the drug. That's determined by the insurance policy that the person or the employer purchases on behalf of their enrollees. We believe that it will increase the cost of these medications to payers and will result in increased premiums. We do think that there is a likelihood that it'll increase costs to the patient themselves, not only through the premiums that the patient is paying to maintain their coverage, but also through enrollee cost sharing or out-of-pocket costs. While the Department of Managed Healthcare and many of the products that they regulate have relatively modest caps on out-of-pocket costs, there are other non-DMHC regulated products on the market that do still have high copays, cost sharing. So if the sticker price of the drug is marked up, it just means that the enrollee is going to have to pay more out of pocket in order to access that treatment. So there is an impact to them, and it could be somewhat substantial for those of low and moderate income. In some cases, again, not in cases from the plans that are regulated by the DMHC, this could happen in a self-insured model or others. It could require the enrollee to pay up front for the prescription and seek reimbursement from the plan if the plan does not have a contract with the provider who's providing the service. That's obviously an inconvenience to the enrollee. And to the extent that those impacts happen, either the enrollee has to pay more cost sharing or in some limited models has to get financially involved in the acquisition of the drug, those higher drug costs can really impact a patient's willingness to go ahead and take medications due to a lack of financial resources. So we just thought it was important to share this kind of big picture perspective with the board. I know while the committee is likely to be focused on different things, whether it's standards or compounding or other types of issues that normally come before you, it's important to remember that our perspective is that this is a contracting issue between plans and providers, and we can come to contract arrangements that either allow or don't allow this to happen, but it's always going to be with an eye to providing the most cost-effective way to deliver these medications for our enrollees to relieve our healthcare system from the burden of higher healthcare costs, and of course, like I said, protect the enrollees' safety as well too. So, taking action that limits this practice for enrollees in California could have some negative impacts, and so we just wanted to outline what some of those are, and that they should be weighed in your deliberations. Thank you very much.
Thank you, Mr. Bakke. Members, do you have any
Maria, I have a
questions? Yeah, okay, go ahead, Greg.
Okay, I have a question for the presenter. Am I oversimplifying this? It sounds to me like the issue that you've presented is that the reason that that the costs are higher for the drugs is because the facility that implements this is adding a markup. So therefore, if they didn't add a markup, does that mean that the white bagging wouldn't be needed?
Yeah, I think I think fundamentally that's correct. If the price differential was the same, there would be less incentive for this to happen. However, as part of a strategy to overall lower healthcare costs, health plans are looking for ways to drive volume through their purchasing. And so, a facility may have a purchase price that, is relatively favorable or is relatively market based. But if a plan, and some of our plans are national companies that are some of the largest insurers in the world, and in cases they might be able to still negotiate a lower price. But yes, fundamentally, I think the reason that we're here today is because when this really got rolling, that price differential was so significant that my member plans were motivated to try and find a solution.
Thank you.
Any other questions? Okay, well, thank you, Mr. Bakke. I appreciate your presentation. We'll now hear from Yvonne, and I hope I'm saying it right, Chong, representing the California Medical Association. Ms. Chong is the Vice President of Health Policy for California Medical Association. Joining her will be Dr. Thomas Semrad with the Gene Upshaw Memorial Tahoe Forest Cancer Center. And I believe they have a PowerPoint presentation.
I don't have a PowerPoint presentation, but Dr. Semrad will. So good afternoon. My name is Yvonne Chung. I'm the Vice President for Health Policy at the California Medical Association. CMA represents more than 50,000 California physicians and medical student members. We'd like to thank the California Board of Pharmacy for convening this informational meeting on white bagging. We appreciate the opportunity to provide our perspective on this important issue that significantly impacts many physician practices, including oncology and rheumatology practices. CMA has serious concerns regarding policies that require physicians to obtain all specialty pharmacy medications administered in the office through specified pharmacies designated by a health plan or other entity. Mandatory white bagging negatively impacts patient care by creating delays in treatment that can impact patient safety, increasing out-of-pocket costs for patients for certain medications, and possibly accelerating physician practice closures and consolidation by increasing costs for the practice, by putting physicians at risk of having to pay for unreimbursed medications. So to start, I'd like to provide some background on how physician-administered medications are managed outside of a white bagging requirement. Generally speaking, physicians purchase the medication from a vendor and then bills the payer for the medication. The medications are appropriately stored on site. They're available for all patients regardless of payer type. The immediate availability of the medications allows the physician to provide the most appropriate treatment and make medical decisions at the point of care based on the individual patient's healthcare needs. We believe that white bagging policies changes this process by requiring physicians to order these medications in advance of patient treatment from specified pharmacies. So one of our biggest concerns is the impact on patient safety. Some medications, as many of you know, are extremely sensitive to temperature and light fluctuations and require special handling and storage to maintain their efficacy. White bagging has the potential for serious adverse impacts on patient safety and delays in care. By removing control over the sourcing, storage, preparation, and handling of specialty medications, physicians become at risk of exposing patients to potentially serious harm and increasing administrative burdens and liability risks to their practices. Next, there can also be delays in patient care. When medication for each individual patient needs to come from specialty pharmacies and is not part of the physician's on-hand medication inventory, patient care is subject to delays in treatment that can be caused by delivery errors, including when, for example, the incorrect medication is delivered, the medication may be shipped to the wrong address, or a medication may be out of stock. Generally, patients requiring specialty medications often have serious and debilitating chronic conditions such as cancer, multiple sclerosis, and delays in treatment can be catastrophic to their care. Due to the severity of their conditions and the complexity of treatment, drugs, and doses must often be modified at the point of care based on changes in patient-specific conditions. For example, changes in weight gain, renal function, a bone marrow function, and results from other lab tests. The inability to make these types of changes at the point of care can result in treatment delays. When medication supplies are managed comprehensively at the practice level, these medications are available to support timely and safe treatment. I'll share an example from one of our physicians of how a patient was impacted by white bagging policies. There was a patient who was receiving treatment who had to spend hours on the phone with pharmacy representatives and had to complete online forms and questionnaires to ensure that the already well-established treatment plan could be continued through the specialty pharmacy. Despite this additional work, the patient's treatment plan was still delayed by 2 weeks. And then when a new treatment was prescribed by the patient's oncologist, the physician followed the requisite procedure, but the patient's care was still delayed by a week. Additionally, some of the drugs required for treatment had to be mixed, and the specified pharmacy was not able to supply these drugs or the pump required to infuse the medications. There are also concerns of instances when a patient requires multiple drugs, but the specialty pharmacy cannot fill all of those prescriptions, which means that multiple drugs have to be ordered from multiple vendors. And because the shipping of the medications may not be coordinated, it can result in delays in care. Finally, the requirements can lead to increased medication waste and patient inconvenience and lost treatment time if patients arrive to an appointment to learn that their medication hasn't arrived or was sent to a satellite office, and the inability to make treatment decisions to infuse immediately following a blood draw while the patient is in the office because medication needs to be individually ordered from the specialty pharmacy. So the patient safety issue is really the most significant concern here. There are also issues with increased out-of-pocket costs for patients. I think some of the earlier presenters addressed this as well. White bagging can actually increase out-of-pocket costs for some patients if the pharmacy does not provide patient copay assistance. So for example, if the cost of drug A is thousands of dollars, but when the physician's office coordinates the copay assistance from the manufacturer, the cost can be less than $100 to the patient. So while there may be a savings to a plan by using a specified pharmacy for procurement of the medication, the patient may forfeit opportunities to reduce their own out-of-pocket costs. And finally, we believe there's a potential to accelerate physician practice closure and consolidation. As was noted, physicians are increasingly subject to white bagging through their managed care contracts. If physicians order through other pharmacies, the claim may be denied. For physicians that are unaware of this policy or how it applies, or those who simply make an honest mistake and order through a non-approved pharmacy, the practice ends up incurring costs with no ability to recoup the cost of these expensive medications. So in conclusion, physicians are really facing an ongoing and unprecedented threat to their own practice viability as a result of the COVID-19 pandemic. According to a recent survey that we conducted, physicians continue to see significant revenue declines, averaging 33% across the state. Additionally, practice costs have increased by an average of 14% to purchase PPE, comply with public health disinfecting guidelines, et cetera. So implementing these types of policies at this challenging time for physician practices only serves to accelerate the financial stress, especially for independent and medium-sized practices. And our concern is that this could result in a new wave of consolidation that would broadly increase healthcare costs and decrease patient access to care. That concludes my comments. I'd like to now turn it over to Dr. Thomas Semrad to provide some brief comments about how white bagging has specifically impacted his practice and care provided in his area. Thank you.
Thank you very much. My name is Tom Semrad. I'm a medical oncologist in Truckee, California, and I do have slides, so if we could advance to those. And we can go ahead and go to the next slide. What I'd really like to do here is, I think we've already heard some of the operational safety and ethical concerns about white bagging, but I think I can do a couple of things, and one of them is really to sort of bring this down to a practical perspective. So I'd like everybody on the call to think for a few seconds about the concept of being in Truckee and you're not on the ski slope and you're trying to provide care. And so I'm going to take a couple of slides just to describe our program and then show you how a white bagging mandate and practice can impact our program. So our program is based on a critical access hospital, which is Tahoe Forest Hospital in Truckee, and was started in 2006 to provide oncology care to an uncertain practice of cancer patients that were in the region. They were basically traveling up and over the pass or into Nevada to try and get oncologic care. The closest California-based infusion is over 60 miles away. And this was very difficult for the community, and the community came together to put together the Gene Upshaw Memorial Cancer Center. Our primary service area includes 3,500 square miles, including basically the entire North Lake Tahoe region. But over the course of the last 15 years, this practice has grown, and because of our focus on quality and due to the huge unmet need, we now have a majority of our patients coming from secondary service and farther away areas, as far north as Susanville and as far south as Bishop. Next slide, please. So in order to affect care in this environment, our concerns really arise from the culture that we have made, and our culture is really about a focus on quality. So we try to address the rural-urban disparities in high-quality cancer care via a patient-centered approach. And one implication of this is a bunch of certifications that we have achieved and for which we get frequent site visits, and we become very sensitive to our care delivery issues as components of quality. And because of the way that our patients interact with our system, coming from far away, often with huge issues related to travel in order to reach this destination, we focus very heavily on seeing the patients on the day of their treatment, on assessing them for treatment on that day, and adjusting their treatment and plans while they are here. This provides a huge financial benefit for patients who may be of limited means who are traveling a long way to come see us. Next slide, please. So the practice of white bagging generates a huge amount of operational concerns for us. Anyone who lives in the mountains gets accustomed to delivery failure. So I heard 2 deliveries go on earlier, and I actually came into the office, so my dogs wouldn't be barking with delivery. But we frequently have issues with delivery here. And we also frequently have issues related to dose changes, delay, and we manage this by having the appropriate stock on hand. And the concept of a insurance-specific specialty pharmacy providing a specific dose for a specific patient is generating a huge cost to our system and a huge staff issue within our system, which puts a huge pressure on our system. So while I respect previous comments about the costs of drug care, there are multiple facets to it that were incompletely addressed and which are a massive challenge for us to try and manage multiple insurance processes, different white bagging processes. Next slide, please. Safety concerns about the drug, I think, are really are something that the State Board of Pharmacy really should have its focus upon. There was an ask earlier that we can really focus on what are the things that the State Board of Pharmacy can pay attention to. And I think this is really the sort of the take-home slide for that piece. We need to understand that a drug is properly handled and stored. We ask our pharmacists in a white bagging process to certify that a product that's been pre-leveled for a patient, developed somewhere from an outside source, is acceptable. And I wonder if that is really okay. Additionally, we have to make sure that in addition to our PAR level so that we can treat all of our patients when they show up of drugs, which is totally impacted by white bagging, we have to also understand that we have to develop separate storage requirements, practice requirements, management protocols, different, and then making sure our pharmacy techs prepare them appropriately when they are supplied totally differently for a different insurance. So the concept of minimizing variation to minimize error is something that we focus highly on as part of our quality program. And preparing the same drug from different suppliers in different settings does not minimize error. And this results in a set of liabilities to our staff and a big safety risk for the patient. Next slide, please. And finally, I think we can argue that delivery failures is something that we get used to. In fact, I just made that argument that we get used to that up here. But it's one thing when it's your Amazon delivery, and it's another thing when it's your oncologic drug, or I guess I could take off my oncologic hat for a second, your rheumatologic drug. There is a risk of cancer worsening if there are significant delays. That's disease specific and very hard to quantify, but certainly happens with some of these drugs. And the risk of psychological well-being if we wind up with treatment delays because the drug is not present is extremely profound in these diseases. And then finally, I just have to put on my ethics hat. I'm the chair of the ethics committee for our hospital district. And I really have to say that this is not providing the same type of care for every patient in front of us. And so we think about the concept of distributive justice, which can be simplified in the idea of trying to treat every patient in the same way. And if we have insurance-specific risks related to movement of drugs and preparation of drugs in a riskier protocol, that is not providing the same care to all of our patients, and we are failing our mandate and our social contract with our community. And with that, I'd be just sort of happy to take any questions and with any other highlights of the reasons that multiple specialty societies and prescribers are very concerned about this practice.
Thank you. Members, do you have any questions? This would be questions to either Ms. Chong or Dr. Samrad. Thank you both for your presentation. We'll now move on to hear from BJ Bartleson, representing the California Hospitals Association. Ms. Bartleson is Vice President of Nursing and Clinical Services for CHA. I believe she has a slide deck also.
Great. Thank you, Madam Chair Serpa and members of the Enforcement and Compounding Committee. As you mentioned, my name is BJ Bartleson, and I am from the California Hospital Association. Glad representing our CHA Medication Safety Committee, composed of many of you listening today. And we are a hospital association taking care of policy and advocacy for over 400 hospitals across the state. And certainly this white bagging policy is one that sort of runs right up our pathway relative to concerns that we're hearing already about from all the presenters, right? We've got some themes happening: affordability, patient safety, financial stress, operational burdens. And I like Dr. Simon's distributive justice. I think that's a really interesting twist that we haven't thought about. So thanks for bringing that up. Well, let's start with the first slide. And again, just to review, I think Maria touched on this, but it has a name. This payer policy change is a move from the buy and bill method. This is how it's called in some respects, where providers buy and store drugs, or where hospitals buy and store these drugs for general use, and then we bill payers for the dose used when they administer the drug to the patient. With the white bagging, the payers reimburse the third-party pharmacies, which then distribute the medications to outpatient medical providers or to us. Next slide. Can you? Next slide. Great, thank you. As we, I think, heard from the previous speakers, this is fairly new, but certainly picking up steam, and is not just a statewide issue, it is also a national issue. And these are the dates that it was brought to CHA's attention relative to the different payers. And if you note, there's different themes from each of the payer relative to the types of payer changes that they're proposing. Would you think about operationalizing this in a hospital, it really complicates and puts a financial burden, not a financial burden, but a huge burden on hospitals who would have to operationalize somehow multiple different patients with multiple different types of insurance. So, for instance, Anthem notified us about their HMO enrollees and that the changes would be respective to them, and then re-notified us in September that the PPO and the EPO plans would be affected. So some of the payers are adding on additional enrollees, and some are doing different themes than others, and they're outlined here for you to see. And I would tell you that Anthem notified those specialty physicians, but didn't notify hospitals. And I think some physicians were not notified. So we did not really hear about this except through our members. Thank you very much, members, for letting us know. We actually raised this with the Department of Managed Healthcare because there is a responsibility on the payer side to notify appropriately. And we were concerned that the notification was coming so late, not only to the hospitals, but to some of the physicians. Next slide. So certainly our concerns were many. And again, that notification issue, payer advance notice requirements were not given to hospitals, which greatly affected them. And we wanted to make sure that people were well aware of these changes so that we could have this kind of discussion and dialogue. So thank you, Board of Pharmacy, for bringing us all together to be able to kind of tease through these issues. From our hospital members' perspective, certainly there were many. So I'm capturing some of these, which certainly will be brought up with presenters following me from hospitals and have already been brought up. But for instance, patient safety and treatment delays, medication integrity, white bagging presents numerous patient safety concerns regarding medication integrity. As has been discussed, the chain of custody policies hospitals use are critical. These are these guardrails, tracking, securing, and tracing medications from the pharmacy. Again, these guardrails are imperative to ensure patient safety, limit medication waste, and eliminate delays in patient care. And when the medication is dispensed from a third-party entity, the hospital does not have control of the medications, handling, storage, and temperature control, et cetera, brought up earlier. So these specific guardrails presently used to ensure patient safety would not be there. Other issues with medication adjustments and timely delivery. White bagging removes a provider's ability to control the preparation of the drug. And in case of these specialty drugs, it's not uncommon for numerous adjustments to be needed on the planned day of treatment because of the patient's conditions, response, changes in lab values, drug tolerance, etc. There's a chance that the third-party payer will be unable to deliver the appropriate drug at the appropriate dose in a timely manner, delaying treatment. Well covered again by Dr. Semrad relative to the issues with timing. Preparation and labeling, another patient safety issue. The identity and dosage of the drug are not known to the provider unless the outside entity has properly prepared and labeled it. The hospital will have to assume that that drug is properly mixed, it is within the manufacturer's labeled expiration date, or has been properly handled before and after the preparation. Medications may also be incompatible with the in-house equipment that hospitals use to deliver infusion. For example, certain oncology medications need specific tubing or infusion machines. Unlike our present buy and bill system, hospitals may lack the leverage with specialty pharmacies and distributors to correct these issues in a timely manner. And I think most important, the impact on hospital operations, which was mentioned earlier. White bagging will result in uncompensated provider expenses to staff, as we will need to be dedicated to the intake and storage of the drug after receipt from the third-party specialty pharmacy, preparing the medication prior to administration, and administering the medication to the patient. And probably most importantly, implementing an increased administrative burden by implementing these policies, because rather than managing a single inventory of medications, the hospital pharmacy would have to manage an inventory for every patient, which can mean hundreds of different inventories for a single drug. Multiply that by different drugs, and the process becomes remarkably complex, requiring additional staff, resources, and expanded storage capacity. So in question here is this theme of affordability and cost reduction, which may happen on one end, but if you think about the complexity of the preparation that would have to happen in the hospitals, then we're looking at cost burden on another end. Next slide, please. So what has CHA been doing as far as advocacy on this? Back around June 2020, CHA was notified by our members of the anthem change that we pointed out earlier. We did meet with DMHC, Mary Watanabe and her staff in partnership with APG and members, and we argued the neglect of advance notification, which I talked about earlier. And DMHC decided that they would not ask Anthem to delay or stop the rollout of the policy, but they asked for us to report any enrollee patient care issues, which was brought up by Sarah earlier. I think it's important that when we do have these enrollee patient care issues that they are explained to DMHC. In July and September, CHA had internal member discussions, and we had external discussions with many groups concerned about this, many of those amongst us today presenting and talking about this very important topic. In September and December, CHA agenda topic at our CHA Managed Care and our Medication Safety Committee, where Board of Pharmacy and Sodergren was present with us. And thank you again, Anne, for letting us be here today to continue the discussion. And then CHA sent a formal letter of concern to DMHC in January. Next slide. I shamelessly stole several of these slides and give great credit is due to Rita Shane and her team at Cedars-Sinai. The next three or four slides, I can't remember, are regulations, Board of Pharmacy regulations. And I think this helps us to take a look at what are our present regulatory structure, both from a state, a federal, or other regulatory structures that help guide us on what we're doing, what we're in conflict with. And I wanted to make sure that I put it in my slides. I will just touch on it briefly because I want to make sure that Rita is able to capture some of the detail that I won't. But I think in answer to some of the solutions that we're looking for, we need to start with the regulatory work. So if you take a look at some things that are in the Board of Pharmacy regulations, certainly dispensing or redispensing, if you will, comes to mind. So dispense also means and refers to the furnishing of drugs or devices directly to a patient. So again, white bag medications are marked as dispensed by the payer designated pharmacy, but not furnished directly to the patient. And interestingly enough, and when I talk further about the other work done by states across the country, this dispense-redispense issue is coming up in both Massachusetts and Ohio as an opportunity for them to look at where there is conflict with white bagging and dispensing of drugs. Furnishing drugs, 4059, furnishing dangerous drugs, there is an exception under sales and purchase record. However, white bag medications are not sold between the designated payer specialty pharmacy and the receiving health system, so really wouldn't fit in there. And then 4119.5, transfer or repackaging dangerous drugs by a pharmacy. White bag medications are patient-specific medications and not considered reasonable supply being transferred between pharmacies. Next slide. So again, thank you to Rita for kind of helping us parcel through some of this work. And most of you are in knowledge of the conditions of participation from CMS. AHA is also looking quite closely at this white bagging issue and is focused on specific information to CMS. Again, hospitals must have pharmaceutical services that meet the needs of the patient. Hospital pharmaceutical services do not procure the medications. And several more under there. And again, I will defer to the experts on more of this as you hear from other presenters. Next slide. There's also the Drug Supply Chain Security Act. Again, this is the security of the drug as it's moved through the system. Payer-designated pharmacies do not directly dispense white bag medication to the patient nor sell them to another pharmacy. Again, lots of conflict in that sort of chain of command or chain of security with the drug itself. And then a few other things in the California Health and Safety Code that might come into play as we review this. And that is the health plan making medical decisions based on financial incentives? And if so, is that in conflict with health plans shall be able to demonstrate that medical decisions are unhindered by fiscal and administrative management? And I believe that came to us from CSHP and Lori Andy Martini. Thank you. And she'll, I'm sure, follow up more in her presentation. So those are some of the additional regulatory conflicts. And I believe in our solution seeking, this would be a place where we might want to start, particularly with our California regulations. Next slide. So other advocacy efforts that have happened, Massachusetts really was out on the forefront in 2017 with white bagging. And I strongly urge you, if you really want to get into this, they put a commission white paper out and did a lot of study and work. And it's led them now to evolving legislation this year on the dispense, redispense piece. And that's the sort of pathway they're moving. And Greg, I would add up, there's also some nice work in there that they've done about contracting. In other words, is this an opportunity to work with hospital providers on some type of contracting issues? I would say, yes, it's probably doable, but again, the patient safety issues would have to be addressed. But there is a lot of work in that white paper relative to contracting with providers on how to move forward. And then the Board of Pharmacy proposed the 2018 National Association Board of Pharmacy Survey and Study. And Maria talked about this. I think the biggest issue here is that few states define the concept of white bagging. While it's been around, it's really not been traditional or done much. Terms and conditions, as we've heard earlier, under payer, not regulator. Therefore, regulatory boards must consider accountability and efforts to protect the public, and the control and responsibility for the integrity and timely delivery of medications under these practices are two issues that remain relative to those of us that are clinical and then to the boards of pharmacy. So it also goes on to say there's legitimate patient protection issues when a specialty drug is distributed to an entity other than the patient. So it's great that we're able to talk about these things while we're here with you at the Board of Pharmacy. Next slide. So again, state progress slide. Thank you, Rita, for putting this together. And there's that Massachusetts and Ohio. They're playing in that dispense, redispense space relative to a pharmacist shall not redispense any medication. No drugs that have been dispensed and has left the physical premises of the terminal distributor shall be dispensed. That might be a place we look very closely at. And then New Jersey and Georgia are focused on other issues relative to diverting patients and pharmacy benefit manager. Next slide. Just recently, 2 weeks ago, the American Hospital Association sent a letter to CMS, as I had mentioned earlier. And interestingly enough, they were thinking widely, I think, about the practice should only be permissible in instances where the provider and health plan agree through their standard negotiations that such arrangements are in the best interest of the patient. And I thought that was an interesting way to look at this. And if you think about maybe not Tahoe Forest, but other rural providers, this may be an only option for them. But what the HA is saying is that providers must be joint partners and safety cannot be compromised. And I think we would all agree with that. Providers should not be required to accept these arrangements when they are unilaterally focused upon them by payers. Providers should be permitted to decline any such arrangements based on quality of care concerns. Next slide. So what are our options? And I agree, we really want to focus on solutions today. And I think we're hearing all the right themes around white bagging. You know, what's right? Is there a leverage or a point where we can kind of do both? I would want the Board of Pharmacy to help us. Is this a public safety consumer protection issue? Those of us from the hospital perspective would say it is. I know that speakers coming up have more examples of such. Is white bagging in conflict with our present state and pharmacy regulations? We would look to the Board of Pharmacy to help us review that and answer that. If so, why? If not, why not? And can the Board of Pharmacy review present state regulations against white bagging policies? And can we all continue to work together and with you, the Enforcement Committee and Board of Pharmacy, to suggest next steps based on all of the presenters here today? So with that, I'll stop and certainly open for questions now or at the end of the presentation.
Thank you. Members, do you have any questions? Okay, thank you, Ms. Morrison. I'm sure we'll have some discussion at the end of the presentations.
You bet.
Now we'll hear from Dr. Dr. Gascari and Dr. Magdaman. I'm sorry about the names, my pronunciation. On behalf of the California Children's Hospital Association, Dr. Gascari is the Executive Director and Chief Pharmacy Officer for Stanford Lucile Packard Children's Hospital, and Dr. Magdaman is the Executive Director of Pharmacy Services for Children's Hospital of Orange County. I believe they also have a presentation.
Yes, thank you. Good afternoon. My name is Grace Magdaman. I'm the Executive Director of Pharmacy Services at Chalk Hospital. We want to thank you so much for this opportunity for us to present the pediatric perspective on white and brown bagging challenges. Together with my colleague, whom I'll hand the mic to for introductions in a moment, we'd like to provide a brief highlight on the various bags that we're dealing with, understanding that we'll be focusing on white bagging at this time. And we want to take you on a journey through the medication management spectrum, from prescribing to administration and monitoring, to identify the risks and failure points that white bagging introduces. While we provide the pediatric angle, we know our adult systems are impacted similarly. Dr. Gascari?
Hi, everybody. Good afternoon. I'm here alongside with Dr. Magdaman to present the pediatric focus on white bagging issues. We have nothing to disclose. Next slide, please. We are going to start our presentation to comparing the different distribution model for a patient to receive infusions. So the traditional model that the previous presenters had a great job presenting is buy and bill, where the hospital clinic provider purchase the drug, store it safely, and give it to the patient and bill insurance afterward. White bagging, or topic of the day, which insurance companies force us to get the drug from a specialty pharmacy contracted with the insurance companies and give it to the patients in their hospital outpatient infusion centers or clinics. Brown bagging is what you put your lunch in, and it's exactly what it is. When you send kids to the school to put the lunch in their brown bag, take it to the school, they bring their drugs to the infusion centers. Insurance companies forces drugs to be dispensed to the patient and convert them to the outpatient center to get it. And the lastly is the clear bagging, where the health system provided a retail and a specialty pharmacy to help if the insurance is forced us to go through pharmacy benefit to dispense the drug, but the same purchasing team, buyer and receivers, and same storage area would be used to use the drug. Next slide, please. Just bring the attention that early on in April 2018, the National Association's Board of Pharmacy was the very first body that looked at in these issues of the white bagging and brown bagging. And what we concluded that there is a legitimate patient protection issue with the white bagging practice. Next slide, please. So I just want to put a visual screen for you to see what happens from the time that the prescriber prescribes an infusion for the patient. For the white bagging, goes to external pharmacy, and they deal with the payers, and they send the drugs to the hospital and infusion center and to be administered to the patient. So as you can see with the next slide, please. There is additional steps. So forcing to get medication to a third party that is completely disconnected from the patient care, without advantage of any adding benefit, going through that and bring it to the hospital. So where the provider and pharmacy and health system cares about patients so much, and we know Johnny Bob, we even know what maybe the kids like for the lunch, where those external pharmacies would only call them member 1, 2, 3, 4, and they do nothing about the patients. Next slide, please. So this is the part that we would like myself and my colleague, Dr. McNamara, to bring you to the journey from the point of prescribing to the point of administrations and highlight the point of failures and risks that might happen. So if you imagine as a prescriber, I would always say the patient's relationship with the provider is a two-way street. At the same way that the patients with the complex care diseases get attached to their providers, providers get attached to their patients too. So when the patient comes and want to receive the infusion, they want to make sure that the patient is okay. The dose is appropriate. The labs are okay for the patient to receive medication. And you can just see how a medication that is being dispensed 2 weeks before, a month before the patient's coming and receiving this medication, how can affect the changes that need to happen, especially in the pediatric patient setting, where the weight of the patient can be changed dramatically. So when the patient comes to receive the infusion, the dose is not appropriate anymore, but we do not have the drug to dispense anymore. So patient has to go back, the appointment has to be canceled. The days off for the parents from work, the days off from schools all goes to waste, and also the delays in the care. So patients' clinical outcome might deteriorate. Being a pharmacist, definitely my focus would be on distribution, the supply chain issue, that you cannot guarantee where the drug was, where it has been stored, how it has been transported to us. So one of the biggest issues for pharmacists and healthcare is recall that happens, and we get those data through our purchasing data. If we are not the one that's getting the purchasing data, managing and connecting with the patient would be very difficult. Also, the Drug Supply Chain Security Act that is really established by FDA to protect the consumer from counterfeit, from stolen, from contamination would definitely be disrupted by this if we are not the one that's buying the drug and we are not supplying. So as I would say, practically redispensing opens up to fraud and contaminations and all other things. So you can see the chain of custody is getting affected. Some of these infusions are a lifetime chance for a patient, like gene therapy. You have only one chance to get curative, to be better. And if that drug is not stored properly, doesn't handle, or is counterfeit, you lose that one-time life chance. Next slide, please.
So when it comes to dispensing, the external pharmacies don't have access to the patient's medical record, so they really don't have the ability to provide comprehensive medication management, particularly during prescription verification. There's often a lack of pediatric expertise, especially in specialty chronic conditions such as metabolic deficiencies and oncology, and this can lead to errors. We've experienced and heard of numerous stories where therapy was significantly delayed due to logistics, delayed deliveries, lost shipments, lack of coordination between drug receipt and scheduling, dispensed drugs expiring prior to the scheduled procedure or appointment, and so on. And these have negatively impacted our patients and families. As far as compounding goes, we know that this is addressed in other presentations as well, but we cannot ask our staff to compound drugs where they can't assess for authenticity and integrity. Further, for hazardous drugs, there is potential for incompatibilities with our safety protections, such as closed system transfer devices. We shouldn't have to create workarounds to accommodate this, nor is it acceptable to eliminate these protections for staff and patients. Next slide, please. And when there are administration-related reactions, we must maintain chain of custody to ensure that contamination or adulteration was not a contributing factor. Pediatric patients also require unique skill sets in delivering care. This includes proper IV line placement in patients with really small veins. It includes appropriate monitoring and even emergency response when there is an unexpected reaction. So when a patient is transferred to another facility because of payer restrictions and that receiving facility is not fully equipped to serve our patient population, it could potentially compromise the patient's care and their outcomes. And finally, with education and monitoring, the providers really take on the full responsibility for the education around the medication and the administration. External pharmacies cannot monitor as effectively as health system pharmacies for adverse effects and adherence and patient outcomes. And health system pharmacies also have direct access to our providers in order to communicate more effectively, more efficiently. Finally, external pharmacies also cannot really perform any required safety monitoring or clearance prior to dose administration of certain specialty medications. I would proffer that it's a risky practice to engage in a dispense without the ability to validate safe administration. Next slide, please. So you can see on this process map where all of the failure points we've just discussed land. We've experienced and heard stories that do not support patient care and consumer protection. For example, there was a pediatric patient who was receiving a white bagged Ciprelin implant for their precocious puberty. And the patient was in the procedure and they were under anesthesia when the surgeon opened the dispensed product, only to find that the medication kit was defective. it wasn't acceptable to close the patient back up and apologize to the parents that they couldn't finish the procedure. So the institution ended up having to provide their own product anyway, and luckily they had one in inventory. We know of another patient who had significant delays in therapy after a hospital discharge due to payer restrictions, authorization denials, lack of clarity in who was supplying medication, which happened to be a specialty pharmacy 2,600 miles away. And consider all of this during a pandemic when shipments are already delayed. This patient also experienced multiple rescheduled visits and infusions that were 8 weeks late. And so you can understand where patients and families not only start to experience disease progression and have stress around that, but have a lack of information coming to them about the coordination of their care. And I'm sure you would agree that this is not how pharmacy practice should look like. Dr. Kasari, I know you have a couple more examples to share.
Thanks, Dr. McLennan. So similar to what Dr. McLennan shared and others, definitely we had several cases that we had challenges. We had one patient that was mentally delayed and had a very hard access, pediatric, getting a vein access for pediatric is definitely challenges, and it's not similar to adult. And after so many denials and appeals and wanting that to service the patients here due to that reasons, we had to force the patient to send to an outpatient infusion center, which is like mostly adult, any outpatient infusion center not associated with health system. And sure enough, the patients get excitable very fast and they couldn't get the access. Patient got excited, so they had to transfer patient to emergency room. So the other example is again with Switzerland. We had a patient scheduled here, a scheduled OR. You can imagine we had an OR ready to go. Parents here at the hospital with patients. We didn't receive the drug. So mom was coordinating with the specialty pharmacy. You can just imagine these patients with a complex care. There's one more thing to be worried about, coordinating about medication that they shouldn't really be worried about patients or patients' families. There are many more examples like Remicade patients that we couldn't get the drug and we had to admit the patients to just get the medications because patients were severely deteriorating. Thank you. Next slide, please.
And so what about that brown bag? There are similar failure points, but the risks around supply chain are so much greater. One of the reasons we bring up brown bagging is that there could be a shift to this practice if white bagging is prohibited, but we want to be able to escalate that this is not really an acceptable solution for the reasons you see on the screen here. These are typical storage conditions for medications, whether they're unsecured for a period of time on a porch or forgotten in a car in extreme heat or shoved in a refrigerator, which is hopefully at the right temperature. Next slide, please. So we'd like to recommend that the board support buy and bill process for patients under the care of the hospital and health system by regulating white bagging. We know in a few of the other presentations that there were other states that had started some legislation around the prohibition of white bagging. And here, we offer one more example from Texas where they prohibit the return and redispensing of a previously dispensed product. We briefly mentioned the clear bagging because, again, that might be a potential solution as things shift within our industry. But we also recognize that that's not necessarily the topic for discussion at this time. And so that concludes our presentation. And again, we want to thank you so much for the opportunity to present.
Thank you so much for the opportunity. We do realize that our presentation was focused on the pediatric, but I do want to say that we know that we are not alone. Adult hospitals share the same. As I work closely with Administrative Director of Pharmacy of our sister adult hospital, Dr. Deepak Susoida. They share the same concerns about patient safety in the white bagging processes. Thank you.
Thank you. Excellent presentation. Members, do you have any questions?
Maria, this is Debbie. I just have a couple questions that were presented. One of the concerns was dosing changes, and it sounded like it was fairly common for dosing changes to be made. I mean, that was one of the concerns. So I guess, are dosing changes made like so far in advance or so close to the time of the patient getting their medication? I know you guys are specifically talking about pediatrics, but is that just a really common situation with specialty medications?
May I try to attempt to answer that question? These could be the medications for patients with like irritable bowel disease syndrome. Those are the patients that due to the malnutrition, their weight changed dramatically. So if they are getting on the process of infusions that every month or something, their weight changes, and sometimes the specialty drug is dispensed in 3 weeks, 4 weeks in advance to the patients, and then they have a patient doctor visit either a couple of days before infusion or on the infusion center, which we noticed that weight has been changed, and then definitely changing the drug and getting a new drug to be dispensed is difficult. Thanks for the question.
So so can I clarify? So you're saying that oftentimes the medication is shipped to the hospital. Did you say 3 or 4 weeks before the procedure?
3 to 2 weeks before procedure, sometimes, yeah.
Okay. Is that common that it's usually shipped, that far in? That seems significantly in advance. So is that pretty common that it's shipped 2 to 3 weeks in advance?
Go ahead. Sorry about that.
Sorry, that's depend on the payers and the specialty pharmacies that they work with.
Yes, thank you. I would just add that it's hard to really have any, I don't think that, because it comes from multiple pharmacies and each have their own practices around how far in advance they would send the medication, and they may not have the clarity or line of sight in when that procedure is. They will do what they do, and then, and so the institutions are oftentimes left to figure out what this coordination of care looks like. And so there is a fragmentation in there that results from that. So it could be a couple of weeks, it could be a few days. Sometimes it doesn't come at all until afterwards. And so I think that's part of the challenge that we wrestle with.
It sounds like there's not a lot of communication between the physician that is ordering the medication and these pharmacies. So I guess if the pharmacy is right there in the facility, then if there isn't any communication, or the doctor chooses not to communicate until closer to the date of the procedure, then that makes it more convenient. But so is that what you're saying, that there's just not very much communication between the facility and the pharmacy?
I think that is there's definitely high potential for that, and that probably happens quite a bit. Except that we have to also recognize that intermediary process that happens between the physician and that dispense, which is the prior authorization piece. And I will say that the prior authorization piece is probably a big administrative process that many, especially outside of the pharmacy world, don't quite understand and have a challenge navigating through, because every payer might be a little bit different, or their requirements might be different. And so I would say that there is a lack of communication between the authorizations and the process, and when it all, whether it's denied or not, and what clinical criteria needs to be resubmitted, that happens in between the physician and the pharmacy. And so, yes, there's that gap that is difficult for the provider, who really needs to spend their time with the patient. That gap continues because of the burdensome processes in between. And that's why we're a big proponent of having the pharmacies that are local to be able to, the hospital, health system pharmacies, to be able to be advocates that are bridging that gap between the physician and the patient.
But wouldn't there still be a prior authorization issue if the pharmacy was, as you say, local? I mean, if there's a process that would still happen. It's just because the payer is the payer. That prior authorization would just happen. It would just be a different pharmacy that the prescriber would work with?
If I can add to that, the pharmacists are pretty equipped with showing that why the patient needs the drug therapy. So where the physician's office might, because then you're dealing with a third party outside a specialty pharmacy, they are not as responsive. That was in our several experience. We had that when the prior auth would sit in the pharmacy and they wouldn't follow up. I think in-house specialty pharmacy are following up faster and more in time to make sure that the patients are receiving the treatment that needed. The other thing that I wanted to add about the rate of the patient's medications for pediatric patients, as many pharmacists in the team would be prescribed as milligram per kilogram. And final dose, that's why we do rate the patients and make sure that the patients on the near the infusions having the appropriate dose. The physician might place a new order, but usually takes time with a third-party pharmacist to process, get it through, and send it back with the new dose.
Okay, and just I think maybe just one last question. You also made a comment about contamination and fraud. Is that, it seems like those are, what I'm trying to do is figure out, situations that having, I think you should call it the local pharmacy, which I think really is a pharmacy within the hospital, that contamination and fraud, would never happen in those pharmacies, but you brought up the word fraud, so there's a possibility that having a remote pharmacy I'm picturing that they're actually sending manufacturer containers, and so I'm trying to figure out why, if it's coming from a remote pharmacy, that there's a higher prevalence of contamination versus if the wholesaler sent it to pharmacy A that is 100 miles away versus sending it to pharmacy B that's within the facility. Why would there be a higher possibility of contamination if it comes from that pharmacy that's 100 miles away?
So I would say, I think the word that I used was adulteration rather than fraud. But what really comes to mind for our ability to detect any contamination, I'll just say, or whether the drug, whether we could assess for authenticity and integrity, is around the Drug Supply Chain Security Act, where we are required to receive transaction history and all this information around the pedigree of this product, and we're not able to do that when the product comes from another pharmacy. And so we're not saying that there's increased rates of this or increased potential examples, but we don't have the ability to mitigate risk should that occur. And we are held to that standard to make sure that we are receiving appropriately vetted product through our wholesalers and even through direct shipments. And so we aren't able to abide by that when the product is coming from another third party. I hope that explains it a little bit better.
I think so. I guess it's because it's a pharmacy to pharmacy that you're saying the pedigree does not go with it.
That's correct. For example, when we are loaning a product from one hospital to another, we are also sending this kind of transactional information with that product. And of course, there's certain situations where what we call T3s are not necessarily required, but if it's not a patient-specific sale, if you will, or transfer, then we are required to send that information so that they can also validate that this came from a wholesaler and it's not counterfeit.
Okay, and so I don't know if this is Ms. Sodergren or Ms. Smiley, but I was thinking that with the pedigree, wouldn't it also need to follow from the pharmacy to pharmacy, even if it's not within the system?
I think that we'll need to look into that. I think that part of the challenge may be where the end product is and whether it's considered dispensed.
I got it. Okay. Ladies, thank you very much for your presentation. It was very educational.
Thank you so much for the opportunity again.
Thank you.
Thank you, Dr. Gascari and Dr. Magdeman.
You got it.
I think we're going to take a 5-minute break. Actually, we have 6 minutes. We'll come back at 2:50 to allow people to stretch a little bit. And so we'll resume with Dr. Rita Shane at 2:50. Perfect. I'll take a quick roll call to assure everyone's come back. Greg Lippy.
Here.
Jig Patel.
Here.
Richard Sanchez. Oh, excuse me, Ricardo Sanchez.
Ricardo here.
I know Ricardo. Sorry about that, Ricardo. Debbie Veal.
Here.
Albert Wong. Albert Wong. Okay, I'm sure he's just running a few minutes late, and we'll announce himself when he comes. Okay, thank you, everyone. We have had some great presentations, and we have several more, so I'm really excited to hear from all of them. We'll hear now from Dr. Rita Shane. Dr. Shane is the Vice President and Chief Pharmacy Officer, Professor of Medicine at Cedars-Sinai Medical Center. I believe Dr. Shane has a PowerPoint presentation.
I do. Thank you so much. And again, I wanted to thank the board for convening this meeting and looking at the issues that we all share and that have been expressed today with respect to patient safety and disruption of healthcare for probably our most vulnerable patient population. So the good news is that I will be able to streamline my presentation, since some of the points that have been raised by colleagues to date have been outstanding and underscore this issue. But I guess as I reflect back on the initial presentations, and especially with respect to the rising costs of healthcare, the issue of drug pricing has been a huge issue for many, many years. It got sidelined because of the pandemic, but at the end of the day, white bagging is a reaction to the high cost of drugs and the exponential increase in drug costs, not only for traditional drugs, where we've seen some predatory practices on the part of manufacturers, but for any drugs that have a significant impact on chronic diseases is pretty astounding. And so it's not uncommon to see drugs that are not only just tens or $100,000 per dose or per course, but we actually have a drug that's $2 million to treat a rare pediatric disorder. So I'm concerned that white bagging is kind of a band-aid to deal with a bigger issue, and we're leaving patients in the middle. The other issue is that patients aren't even aware what this practice is, and so they haven't had an opportunity to be even knowledgeable or have it explained to them to understand what's happening behind the scenes as we try to deliver care to them. Delays in cancer care do occur. I think the questions were, well, how often do these delays occur? Delays in cancer care do occur. There are also clinical issues, which I'll touch on, that are maybe slightly different than our pediatric colleagues touched on, that really leave patients in the middle. And so I guess one of the things we're trying to work on together, all of us here that represent clinicians, as well as those of you that are on the board, trying to figure out how to navigate this, is how do we look at the current regulatory language in the landscape and see what we can do to ensure that patients aren't caught in the middle of this, what I'd call tidal wave that occurred over the last year that coincided with the time we were all managing a pandemic. So I will be able to go through a number of my slides quickly and give others a chance to speak, ask questions, and comment. Next slide, please. We're not going to talk about this. You've seen this. Next slide, please. And this is also, I think, BJ went through this. So again, I told you I'm going to be able to focus and will attempt to not be redundant. Next slide, please. Again, BJ called this out. Just go back one quick thing. I think all of this was discussed. This kind of whole existing regulations and conflict. Next slide. This was also addressed. Next slide. The other thing, there was a question about, and I think that our pediatric colleagues explained this Drug Supply Chain Security Act. The integrity of the product is something we're responsible for, and storage conditions do matter. So even though these drugs are coming from another pharmacy, we don't know how they were sourced. We don't know how they were stored. Something could be sitting in a truck in traffic, and I live in Los Angeles. Maybe that doesn't happen today because of the pandemic, but sitting in a truck, we don't know how these drugs are being stored and whether or not they were sourced appropriately. So I think that I just want to underscore what was previously mentioned. Next slide. And with respect to the states, not only is the redispensing has been called out in Massachusetts and Ohio, but there's also language in New Jersey and in Georgia really about taking away patients' freedom of choice. And so one of my thoughts, you know, especially reflecting on the comment with respect to our ethical responsibility in this whole world that we live in, is patients are supposed to have choice, and they are not aware of what's going on with respect to this whole process and how it could be affecting their care. Next slide. So the safety conflicts have been touched on. I just wanted to call them out. The American Society of Clinical Oncology has come out to recommend bagging in general. The National Comprehensive Cancer Network really talks about standardization. I think this was well said by Dr. Samrand, who's an oncologist. There are 57 checks in chemotherapy. Those were developed, just about 30 years ago when a reporter for the Boston Globe by the name of Betsy Lehman was overdosed on chemotherapy. And since that time, efforts have been made throughout every system and every provider in the country to ensure safety of chemotherapy. This is the most dangerous thing that happens to patients when they're treated. And the death of Betsy Lehman and subsequently followed by the death of another patient at the University of Chicago underscored the importance of all of the checks that are put into place to ensure the safety of the chemotherapy, which is why having the chemotherapy drugs available is important, so we can perform the 57 checks that have been documented in the literature. Having patient-specific chemo for every single patient with all of the comments that have been made disrupts and fragments care in an exponential way. And can you imagine the hundreds of patients of drugs that are being stocked in different strengths, because chemo has a wide range of doses and the vials are not all based on what the patients can receive. The dose changes based on the chemo that we are providing the patients. The same thing is true for inflammatory bowel disease. The same thing is true for transplant patients. The same thing is true for rheumatology patients. The patients that are receiving these specialty drugs have chronic diseases that are debilitating, which in the past we didn't even have drugs to treat with. These patients, if not treated effectively, are going to end up back in the hospital and increase healthcare costs, or they'll have a delay in disease progression and end up dying because they won't get the cancer chemotherapy in a timely manner. And yes, there is data to support that delay in chemotherapy does result in disease progression. I'll show you an example at the end of my presentation. And lastly, the National Coordinating Council for Medication Error Reporting and Prevention also speaks to standardization of process and to prevent error-prone aspects. The one principle in medication safety I can tell you, and I've been in practice for 43 years, is you don't add steps to a complex process because that just creates more potential for harm. The Swiss cheese that we know in healthcare, when the holes line up, bad things happen. It's like when the plane crashes. Well, when there are too many pieces of Swiss cheese or too many holes, there's going to be harm. Next slide. So we've heard about patient safety challenges. I'm just going to touch on things that haven't been discussed and maybe help to highlight what this concern is about not having the drugs available. We've heard of more delays than we've seen drugs come in advance. And even if the drugs do come in, things change. Patients have visits the day of or the day before they're scheduled for their medications. It could be they lost weight. It could be they gained weight. If they gained weight, we may not have enough drug. We might get information back. Labs have changed. That would change even the regimen itself. There could be biomarkers that have come back that would change the regimen altogether. There are patients who have come into our transplant center who need to have a drug that day. Otherwise, they're going to reject the organ that just got transplanted. This does occur on a regular basis. So there are lots and lots of examples of just-in-time need to be able to pull the drug off the shelf and make it up for the patient based on patient-specific factors. And if the drug is not available, the patient will be treated. With respect to discharge, if a patient's going to need to get a specialty drug for administration post-discharge, we may not be able to discharge the patient because we need to make sure that drug is going to be available. And if there's a delay in the drug coming in, we could end up with a readmission. So again, increase in hospital costs, fragmentation of care in response to the high cost of drugs. So this solution is not a solution that really does benefit the overall reason most of us went into healthcare. Anybody who's in healthcare did it because we want to make a difference in patient care. So it's not most of us. We didn't go into this business for any other purpose than to care for patients. Next slide. One thing that hasn't been touched on is how orders are built into electronic health records. We've spent the better part of this century making sure that we have electronic health records that build out these complex drug therapies, not just for cancer. If someone's getting a drug that is needed for chronic disease, chances are it's going to affect the immune system. A lot of the breakthrough drugs that are in the specialty space affect the immune system. I call it immune bartending. So what's really important before any of these drugs are even given is to evaluate the patient and make sure that certain checks are put into place. It could be laboratories. It could be finding out if the patient had an infection within the last 2 weeks. Were they on an antibiotic? Did they get any sort of other drug that would be a contradiction to getting the medication? And with cancer chemotherapy, the orders are totally built out with supportive care of laboratories and all sorts of things like hydration and other things that need to happen to the patient. I always say these orders have to be built with belts and suspenders. There's no such thing as a naked chemo order. It has to have clothing on it. So these have been built out elaborately. The courses of therapy, the number of drugs, how frequently they need to be given are all built out in an electronic health record. How does that get transmitted to the specialty pharmacy? Does that mean the physician has to call in the order each time? The reason these were built, and our organization spent 9 months building out our records for some of these complex therapies. I'm sure others have as well. The reason they were built is to prevent the death that happened 30 years ago with chemotherapy and the deaths we used to hear when the orders were written and they weren't written in such a way that we could ensure that the order was complete. And in pediatrics, it's weight. In adults, it's weight as well. A lot of these drugs are weight-based. Some of them are body surface-based. All of that has to be built in to the electronic health record to ensure the safety of the drugs that are being administered, whether it's in an outpatient health system, infusion center, or in a provider's office. And if that is how that order then gets transmitted to the specialty pharmacy creates duplicate work for the provider. I don't think we want our providers spending their time trying to make sure they called in the order correctly or they remembered to call in the next course of therapy. A lot of these drugs, in fact, most of them, not just for chemotherapy, have to be given every 4 weeks, every 8 weeks. There's a different frequency depending on the disease and depending on the patient's condition and how they're responding. And for transplant patients, it can be variable as well. So I don't understand why we would want to take providers who are critical to the care of these patients and managing these debilitating diseases away from their care that they provide in terms of diagnosing, caring for the patient, and often caring for the family for the purposes of calling in orders to a third party and disrupting a safe system that we've spent months, if not years, building. It's taken 20 years to get these systems up and running to be safe and effective. We've talked about the patient disruption. We've talked about all the operational challenges of housing these hundreds of patient-specific drugs. And with respect to even the compounding, because these drugs almost all need to be compounded, the state board has, as a measure of safety, has asked that we have master formulas. Well, if we're getting different strengths of drugs than we usually use, now we've got to create a master formula, just introducing another delay, another step into the process. More steps, more harm. Next slide. Louisiana actually had this legislative action letter that I wanted to share based on their own experience, and I think it's important to look at what's happening around the country. And the concerns are similar to what you have heard. Patients have been midway through their chemo regimens when these new payer policies have been enacted. So these patients now have to figure out where they're going to get where they're going to get care, or the healthcare system or provider is going to provide the care and not get paid. I mean, leaving the patients in the middle is just unethical. And when patients do need assistance and trying to figure out where to get care, and at least from the Louisiana State Board letter, that's not been something the payers have been able to provide. Next slide. So here are a couple of examples. Patient with multiple sclerosis treated since 2015, white bagging policy goes into place. Patient is needing additional induction and then periodic treatment and was significantly delayed from the specialty pharmacy and then had to make arrangements to get it somewhere else. They'd been treated for over 5 years in a stable facility and then had to go find care elsewhere. Another patient with hepatocellular cancer, you can see the order was placed 10/6. The denial received 11/16, over a month and 10 days later. Patient's disease progressed. Delay in therapy of 1.5 months. Patient has had disease progression and had to be admitted because their cancer got worse. From my perspective, I went into this business to take care of patients. I have collaborated with people across the state and across the country, and the commitment that any of us made who took the oath of a pharmacist was that the patient comes first. High-cost drugs should not impact patients in such a way that when they are the most vulnerable, we cannot provide the care that they need because we're going to be distracted with white bags of drugs coming in. What we should be doing is ensuring they get the best possible care that we can provide them. Thank you.
Maria, this
Thank
is
you.
Debbie. I actually have a question for Dr. Shane on this last slide.
Sure, go ahead. Maybe we leave the last slide back up. Does that help? Go ahead, Debbie.
Yeah, Dr. Shane, so in the second example with the prior authorization, wouldn't the prior authorization have been necessary regardless of where the person got there, regardless of the pharmacy?
Well, because of this white bagging, there's additional prior auth built in.
Wait, say that again?
With the white bagging, there's additional prior auth built in. There's a lot of prior auth that's been put into place, not only for white bagging, but other issues as well. So this is just additional prior auth.
I see. And then it seems like a lot of what you point out has to do with communication within the healthcare team. And so it sounds like it's just a barrier for that healthcare team to include a pharmacy that's outside of the facility.
The way that we go ahead. I'm sorry, I thought you finished your question. So please.
I did.
So the way that healthcare is provided, especially for complex care patients and pediatrics, and you can think about patients. This actually is in the acute care setting as well. Yes, it's a team approach. The pharmacist places, the physician places the treatment plan, which is then integrated with pharmacist workflow and the nurse workflow. All of that is part of what happens in an organized healthcare setting, and a similar model, as you heard, occurs in oncology practices. The adding another, if we're going to add another pharmacy, then why they're functioning as a wholesaler? What purpose are they possibly serving other than reducing the cost of healthcare to the insurance at the expense of fragmenting the care? I mean, patient-specific medication orders would be analogous to go into a restaurant and everybody would have their own steak sent in. It just doesn't even make any sense having to stock every single patient-specific medication. And then, as I said, oftentimes it's not going to be what we need. It's not uncommon that patients' therapies change, and we have to just in time change it. I mean, it does happen. So it doesn't make any sense to, after the years of putting together comprehensive systems for safe care, where we have been able to achieve outcomes and not have errors, to add another party into this whole process. Because drug pricing is high, therefore we should have white bagging. It just makes no sense.
Okay.
Maria, may I ask a question?
Sure, go ahead, man.
Back a few slides, Dr. Shane, you talked about that most cancer patients are on 2 to 3 medications.
Yes.
In your experience, is it typically the same specialty pharmacy that's providing all of those medications, or is it that it could be different specialty pharmacies based on the medication?
Some could be specialty, some could be some could be ones we have to buy. It could vary. So we have to buy some, and then we have to wait for the 2 from the specialty pharmacy. We're actually not allowing white bagging right now, but that's the way that it's set up, because I've spent a lot of time learning about all this from colleagues of mine across the state and across the country. So it could be that they're coming from different places, meaning we get some and the expensive ones come from the specialty pharmacy. And then remember, each payer has different specialty pharmacy arrangements. So we're getting drugs from, if we were to allow this, we would be getting drugs from a myriad of sources, and we'd never be able to verify that they were stored appropriately or sourced appropriately. It's basically going, imagine shopping on Amazon, Walmart, and pick your favorite, Target, whatever, and getting everything from every different place, which is the same stuff. So you're going to get 6 brands of toilet tissue, or 6 toilet tissues in different containers. Sorry to use that analogy, but during the pandemic, I was hoarding toilet tissue because there wasn't any for a while. So I got really creative and it got very confusing.
Thank you.
So, Dr. Shane, you said if we allowed it. So, what's your organization doing right now? Are you not accepting these orders from outside?
That is correct.
And so, what happens to the patient in that situation?
We're very upset right now about this whole situation.
So, if you're
trying to help the patients get redirected.
Okay.
And we can't verify that they have the same level of comprehensive assessment and the partnership that we have with our healthcare team. Cancer and all these specialty diseases require expertise. Just as physicians specialize in oncology, so the pharmacists specialize in these disease states, pediatric pharmacists have specialization. We don't really know the level of care that they're getting. You know, these policies went into effect in varying times over the last year, and so I think the outcomes you started to hear are what we're going to continue to hear with patients who are stuck in the middle or may have delays in care.
So these infusion suites or whatever, maybe some of them are experts in some diseases, but you question whether they are as robust in a variety of diseases as your organization.
And the organizations that have spoken today, it's not just my organization. I think that's why we have so many people speaking. We've all endeavored to make this as safe as possible for our patients by ensuring that we have the partnership with the clinicians and that the people that are doing this work have the knowledge and skills and expertise to ensure safety. These drugs are tricky. They're not simple prescriptions where it's, you know, one tablet, as if anything is simple these days. But infusions in it are extremely complicated.
Okay. I mean, it seems like these companies that the insurance companies are pushing these people to, these infusion companies or whatever they are, it sounds like maybe there's been some issues at their site that has caused some of this, has been not the best for the patient.
Well, some pharmacies may be accepting white bags and dealing with all the myriad of issues we've talked about with delays or not having the drugs available. Others may be saying we're not accepting white bag, in which case the patients are going to the various infusion centers and being seen there. So there's probably a variety of different models depending on the organizations to how this is being managed. But at the end of the day, patient access is being disrupted. Patients are being directed to other sites potentially, or patients don't know that this is going on in the background that could jeopardize the care that they're receiving, since this was done without the patient's involvement.
And so I guess my question is these other infusion sites, it sounds like they're, I'm not sure who regulates them, but it sounds like maybe they're not up to the standards that, or have peace.
They will say, well, CVS is, CVS has ambulatory infusion. By the way, CVS had record profits last year. I just happened to look that up while we were talking about healthcare financing. And I'm not here to disparage any pharmacy program. They're accredited. I'm not here to in any way disparage anyone. I'm just saying that we are committed to the partnership that we have working with our physicians and our nurses to provide the best care in our health systems, and you heard there are similar models in provider groups. So it would be disrespectful of me to talk about something that I don't know. What I do know, because I've spent over 40 years in practice, is what happens in the places we've been providing this care and how hard we work to make it as safe as possible.
Thank you.
Any other questions for Dr. Shane? Okay, thank you, Dr. Shane. I'm sure we'll have some questions from the public. Now we'll hear from Dr. Stephen Thompson, representing the California Society of Health System Pharmacists.
Great, thank you for having me. I want to thank the board for addressing this very, very important issue. My name, as mentioned, is Steve Thompson. I'm the Director of Pharmacy at Torrance Memorial Medical Center down in the Los Angeles area. I am the past president of the California Society of Health System Pharmacists, and I'm here representing them today. As you know and have heard by the excellent presentations already mentioned, coming toward the end, there's not a whole lot more that I think I can add because a lot has been said on the thing, but I'll go through a couple things that I wanted to maybe stress a little bit. We have CSHP does have similar trend, similar point of view on this. This is an ever-increasing trend that we're seeing more and more, and it's just continuing to expand. And so, it's so important for us to take this opportunity to address this as we can now. As mentioned, there's many societies and many legislative activity, many boards already looking at this issue. A mention was Louisiana, Ohio, Texas. Massachusetts has their legislation going in. The National Association of the Boards of Pharmacy, as Chair Serpa and BJ brought up earlier. No reason to go into any of those more. Also, BJ brought up the American Hospital Association drafted the letter to the CMS, urging them to use their authority to prevent some of this process going on. So specifically, they were in looking at the United Healthcare at that point in time, but it's a bigger process than that, or bigger issue than that. I'll just mention that Torrance Memorial does not allow white bagging, so I'll just put that out right at the very beginning. Some of the reasons were already mentioned, or most of them have already been mentioned. The Drug Supply Security Chain Act, the delay in delivery is a potential. We talked about the weather. Well, anybody that's dealing with the COVID vaccine distribution right now knows that the weather in the Midwest and back east has prevented some of our vaccine getting out to the different locations. So delivery is a real issue with weather, whether it's the weather issue or just traffic. So the other thing that I know that Rita touched on quite a bit is entering these medications into our computer system. We have done a lot of work, as Dr. Shane has done, with the order sets, making sure that they're complete, being vetted through multiple departments as well as multiple committees, making sure that these supportive orders are there with them, whether it's be the lab, dietary, the other medications, all of that has been put into order sets that make it and does the checking up front before we even get to it, so that we know that it's safe. So, and that's a timely process. So it's something that you can't just do on the fly. So the other thing that we have done is we do barcode scanning on all of our medications, so that we are doing checks on making sure these medications are safe for the patients and they're getting to the right patient. So when you get these white bag drugs in, they're oftentimes put into a system that is non-formulary, and so it bypasses a lot of these safety checks. So we have to be very careful. We did talk quite a bit about dosage changes. They are frequent. They do happen. A lot of times a patient will come in and maybe even have a radiological exam being done, and then based upon the outcome and the progression of the disease, they may even make the order change based on that. Lab values, weight changes, of course. What we do is we work obviously hand in hand with the physician. They're right there. We're discussing what we need to do with this, and it's a team approach, as Dr. Shane had mentioned. So it's something that we are proud of and feel that we're doing the best for our patients. When you look at an outside pharmacy getting this information in, they don't have the history. They don't have all the patient information, the medical history in their profiles like we do. So they're just getting a medication. It kind of gives me a feeling of when the insurance company have a preferred formulary and they want to make a change to a patient's medication because this one's preferred. They're either getting a better cost or whatever. And then it goes back to the pharmacy, and the pharmacy has to say, well, your drug's no longer covered by your insurance plan. You have to first try this. Well, it turns out, they don't know that the patient maybe already tried that drug and had failed on it. So it goes back and forth. And so having a complete medical history, having that information available for our patients and being able to work with that practitioner is real important for us. A couple other things that I wanted to mention was, unfortunately, as Rita had mentioned or Dr. Shane had mentioned, is that sometimes when the hospital doesn't allow this practice, it does drive the patient out of the systems. which leads to an incomplete medical history then. So when the patient comes back into our system, we don't know exactly what was going on with that. We also, and I didn't like to bring up cost because cost is not really why we're in this, but it has been brought up a couple times. Sometimes we're not a 340B hospital here at Torrance, and so what we do is we do have contracts with multiple health insurance plans, and so what happens is a lot of times I'm doing good just to break even on some of these drugs, but it's never really been about the bottom line for that. It's about taking care of the patient and taking care of the patient properly. And so unfortunately, this process does seem to put this patient in the middle and makes it very difficult to take care of them in the most appropriate way. And I think that's all I have for right now. So I want to again thank you very much for giving me the opportunity to speak. And if there's any questions, I'm open. Thank you very much.
Maria, are you unmuted?
Is Dr. Our next speaker is Dr. I was speaking. Can you hear me?
No, you're breaking up. We hear a few words, but that's it. We didn't hear the name of the next speaker.
Can you hear me?
Yes. Can you hear me?
Good afternoon. I can introduce myself if that's okay.
Yeah, please go ahead. Sounds like
Is
we're
this
having
better?
trouble. Yes. Yeah, you keep going out. Go ahead, introduce yourself.
I was going to say, Greg, I hear you perfectly. I don't hear.
I know, we can't hear Maria.
Oh,
So,
and I heard the speaker, so I agree with you. I think the speaker just go ahead and introduce yourself.
Okay. Well, thank you. Thank you, everybody. My name is Chris Azizian. I'm the Chief Pharmacy Officer for Keck Medicine of USC and Chief Regional Oncology Officer for Keck Medicine of USC as well. And thank you for allowing me the opportunity to speak to you today. I think I, like my colleagues who have presented, especially Rita, will probably jump through most of my slides and really try to focus on some key areas. So if we can go to the next slide, please, and then the next slide, and then one more slide. Okay, so I think we all know the definition by now. I think it's important to just pause and ask, why is this an issue now? I think, as we've heard, payers are suddenly rolling out major policy changes as a result of cost of care and trying to reduce cost of care and cost of care initiatives. It's also important to note that there's been, throughout the past several years, vertical integration. You've seen payers purchase pharmacy benefit management offices, and now they have specialty pharmacists, and so pharmacies. And so to that end, a lot of that business is being brought inside. Although the focus of this is not really the dollars and cents, it is important to mention these specific things. There's also a transition from the medical benefits to the pharmacy benefits, but this adds an additional layer. As has been mentioned, it's confusing to our patients, it's confusing to our providers and physicians, and frankly, it's confusing to most of us and our authorization folks. And at the end of the day, making these unilateral policy changes is left to the organization to try to care coordinate. And so that is a lot of burden to be placed on health systems and our providers. And as Rita mentioned so eloquently, we want our providers taking care of our patients, not really having to deal with the bureaucracy of having to coordinate and manage these types of things. So I just really wanted to stress that point because it is becoming increasingly frustrating. And ultimately, there is impact to patient care and patient safety. And, you know, for the pharmacists and for the pharmacy teams, there are major conflicts, at least based on the way we interpret most of the regulatory requirements that we are required to oblige by. Next slide, please. I'm going to probably skip the next 4 slides, but I do want to mention, and these are exactly duplicates of what Rita and our colleague from CHA presented. I can count probably 8 regulatory statutes or requirements that we feel white bagging has a conflict with. And if we can go to, if we can skip, next slide.
Good afternoon. This is the co-moderator. I'm going to go ahead and advance, and please tell me when to stop.
Stop, please. One back. Thank you. I do just also
There you are. Thank you.
Thank you. Thank you very much. I do want to add that in addition to all the regulatory requirements, we do have Joint Commission requirements. Again, much of this is around procurement, storage, and preparation, safely preparing these drugs that white bagging directly conflicts with. And I realize Joint Commission is an extension of our CMS, but definitely wanted to call that out as well. Next slide, please. Thank you. When it comes to safety and waste, and I think I can probably summarize this in one sentence, shipment loss and delays will result in postponement of life-saving therapies, and ultimately in increased waste. As again, most of my colleagues pointed out, including Rita, most of these drugs are ordered in advance, but patients will come in and will require laboratory results on the day prior to infusion or on the day of infusion, as well as a physical examination, which may force the provider to change dose based on weight, or delay dose or cancel dose, or change to a different regimen. Whatever the case may be, we're no longer going to be able to reuse that medication because it came to us from an external pharmacy. Next slide, please. One more thing to note, and again, I think folks pointed this out by mentioning the electronic health record. We don't feel that external pharmacies have the same capabilities to provide the same level of pharmaceutical surveillance and safeguards. And it's not a competency issue. It's not retail versus acute care. It's more that you don't have access to the clinical information that the acute care site has. In order to be able to fully evaluate a patient, you need access to all those records. And you need to be able to go through the process of drug interaction checking, and essentially the provider's assessment of the patient. And so all of that is in our records, which is distinctly separated from the external pharmacies, which causes a problem and a barrier. Let's see. Lastly, I think, again, this is going back to the DSCSA regulation. And really, one of the things we're required to act on is recalled products. And not having the appropriate pedigree information associated with the medication because it's coming from an outside pharmacy is going to certainly make it very difficult for us to act what we're required to do when it comes to recalled products. Next slide, please. Okay, here I just wanted to provide some specific examples, and I think Rita has had some similar examples, but the top example, we have a 64-year-old female that had brain cancer and melanoma. There was a 1-week gap in treatment caused by sudden payer mandated switch to white bagging. And so, we had to switch from medical plan to pharmacy benefit plan. It was a sudden change. This payer had already seen our provider, was scheduled to come in, and now we had to redirect basically to to a specialty pharmacy. The next one was a 59-year-old male with colon and liver cancer. The physician just gave up because there was so much coordination to do. They switched treatment from an infusion therapy to oral therapy to avoid gaps in care. And I believe someone else had asked this question. The reason why this is even more confusing is because some of the drugs, these are targeted drugs that the payers are requiring to come from specialty pharmacy. So some of the drugs have to come from them, and some of the drugs have to come from us. And it's extremely confusing and laborious to try to sort through all of this to deliver appropriate care to the patients. Again, it's confusing to us, confusing to the patient as to why one drug has to come from a different source and the rest we have right on the shelf ready for them to go. And so to that end, there was a change in this particular scenario. There's a 60-year-old male with neuroendocrine tumor, 2-month gap in treatment caused by a patient's inability to afford their share of cost as a result of converting from medical benefit to pharmacy benefit. And so this kind of, I realize this is an anecdotal example, but this kind of goes to speak to the points that were made earlier about how cost of care essentially ends up translating to the patient. In this case, it did not. It worked exactly the opposite direction. 54-year-old female with liposarcoma, patient pending hospital discharge. This is a totally different example, but we face this on a regular basis. We can't even discharge people because we can't get drugs that are supposed to come from a specialty pharmacy prior to discharge for these patients to leave the hospital, causing delays in discharges. And I know some of you may be thinking we need to put in the prescription much sooner than later. And in this particular case, I believe the prescription had gone in about 2 to 3 weeks in advance prior to discharge. And so we definitely do see delays in care and delays in deliveries and lost shipments, et cetera, affecting patient care. Next slide, please. So what are we doing at USC? I think we're with Dr. Shane and some of the previous presenters. We have a strict policy that prohibits white and brown bagging. And that's primarily because we are not able to meet the regulatory requirements, federal and state, that are imposed on us if we were to allow white bagging. There's no other reason for that. We are sending out patient letters proactively with an option to file a complaint with DMHC. So to my DMHC colleague, thank you for being online, and I anticipate you're going to start seeing increase in complaints. We have to constantly communicate to our providers because they are confused. They are getting many questions and emails from their patients as to why they cannot see them or they cannot get their care delivered at our cancer center or at our Keck Hospital, which is a tertiary quaternary hospital. We have to organize town halls. I mean, all of this effort to try to educate everybody just because there was a sudden unilateral decision to make a policy change. And most of these payers, by the way, we have been in close negotiations with. Some of these payers recently negotiated contracts. There was no discussion around policy changes about specialty medications. And so we're very puzzled. Our contracting team is very puzzled. Everybody is puzzled as to why these things are happening so suddenly. We continue, despite all of this, to attempt to resolve with payers through and try to identify business solutions, although it seems that we're far from arriving to solutions at this point. And again, we stand united with our colleagues in asking our board at this point to advocate for our patients. Next slide. I think Rita touched on this. This is what other states are doing basically to address this issue, so I'm not going to reiterate this. Next slide. So here's our summary and ask. Really, we're asking our board to evaluate the public safety risk and take swift action. Review and revise current regulations to prohibit unilateral payer-mandated white bagging policies. Review and revise current regulations to prohibit unilateral exclusion of health system-owned specialty pharmacies from payer networks. If oversight of these policies is outside of the BOP jurisdiction, then we're asking our board to advocate and collaborate with stakeholders to adopt appropriate regulations. to prohibit our payer-mandated white bagging strategies? And lastly, if none of this works, please tell us what to do next and what next steps to take. And with that, I'll end. Thank you for listening to me.
Thank you. Maria, are you back? Okay. Not hearing from Maria. This is Greg Lippy, board president. I'm going to step in. Moderator, I do not have a list of presenters. So are there other presenters now?
Hey, Greg, this is Debbie. I just have a couple questions.
Okay. Go ahead with your questions, but then I want to find out if there are other presenters too.
Okay.
Go ahead.
That was a nice presentation. I keep being confused by, there's been some references by a couple of the presenters about medical benefit versus pharmacy benefit. And I think in your presentation, maybe the light clicked on with your one example of that patient who their medications were covered through the medical benefit, and then when it flipped to being covered under the pharmacy benefit, it changed their copay structure, creating a situation where they were not, where they were actually couldn't afford their medication. And so I guess can you just explain that further rather than me try to figure out how to ask the question, and maybe I can find that question.
Yeah, so in switching to the pharmacy benefit portion, depending on what stage the patient may be, there's a deductible that they have to meet. So it could very likely be that they have a very high share of cost, a high copay, high share of cost, however we want to look at it. They may be in a donut hole, who knows? And so at that, for this particular patient, the cost was so high, and just so I comment, is we don't leave folks high out to dry in most situations. We do have charity care programs. We do apply for we work closely with our pharmaceutical industry to see if we can enroll folks to receive medication either at a lower cost or for free. In this scenario, we were unsuccessful in getting any resolution for this patient, and so to that end, the patient ultimately decided that they, because they couldn't afford it, they would wait for the beginning of the year and seek potentially a different insurance to restart their treatment.
And so if it's covered under the medical benefit, can like any pharmacy play, and including the pharmacy that's part of the facility, but when it becomes part of the pharmacy benefit, then that's when the payer or the employer, whoever, gets to say only these pharmacies can provide services?
Yes, exactly. And so I think that was one of the other points. We were asked not to discuss clear bagging, but if I may, in answering your question, clear bagging is exactly that, is most of these health systems have specialty pharmacies that are just as capable as CVS Caremark or Credo and any other of these pharmacies to dispense these medications. However, they're being excluded from network and not being allowed to have access, and therefore redirecting the patient to those particular pharmacies. So if I have one of my pharmacies and I can run things through the pharmacy benefit program, and I understand, because it's our pharmacy, I have complete control and custody over the medication and its chain. I'm much more comfortable using my pharmacy to accommodate this than bringing an external pharmacy for which I have to take liability. So that's one thing, and I don't know if that answered your question, but I think the facility, to answer your first question, the facility bills the plan under the medical benefit. When you move things to the pharmacy side, they can only essentially bill the pharmacy benefit things, and it's a completely different copay structure and share cost structure.
Okay. That kind of clicked on some lights for me. I'm understanding a little bit better the part of the issue here. And then Anne, or maybe Eileen, we've heard a couple of times about Massachusetts and I guess taking medication back and redispensing it. I was thinking within the state of California, our pharmacy regs would not allow that either. Is that true?
Debbie, I think we probably need a little bit of time for staff to work with counsel on that before I give a specific answer. I think in Massachusetts, they are taking a different kind of approach. I think Ohio is perhaps the state, but others can correct me, where I think they have prohibited the redispensing of a previously dispensed medication.
Okay. Thank you.
So this is Maria. I'm back. I'm on a different computer. Can you hear me?
Yes, thank you.
Thank you, Greg, for taking over. And thank you, Dr. Galigian, for introducing yourself. And I apologize for the delay there. Members, do you have any other questions for Dr. Galigian? Okay, thank you. Let's move on to our final presentation of the day, which is from Dr. Diane McGowan, the Director of Pharmacy representing PIH Health. And I believe she has a slide deck also. Here it is.
Thank you very much for having me. My name is Diane McCowan, and I am representing PIH Health Whittier Hospital, where we run an infusion center through the hospital and purchase our drugs via our hospital pharmacy to supply it. We have 3 oncology pharmacists, 1 oncology technician that works very, very closely with our group of oncology physicians to coordinate the care for our patients. So it took us a little bit to figure out that we were all of a sudden getting white bagging. They just started appearing. Nobody called us. We had no idea that they were coming. They just kind of started showing up. And that's when we became very concerned. Next slide, please. Next slide, please. Oh, thank you very much. We've talked about the acquisition of drugs in a lot of the previous ones, but I did want to point out there is one more regulation, 1735.3, that says that we need to maintain records for the proper acquisition, storage, and destruction of chemicals, drug products, et cetera, used in compounding. And when we get these from a secondary source, we're unable to achieve this regulation. We've talked about the Drug Chain Security Act and all the problems with that. Next slide, please. The standardization of delivery has really been interesting. I don't think some of the specialty pharmacies that are sending the drugs to us know exactly what they're doing. Sometimes they call our patients and ask, do you need this drug next week for your treatment? And that patient was confused and said no, so they never sent it. Another one was called and asked to go and pick it up when it should have been a white bag. And she showed up at our door and said, I don't know what to do with these. We don't know what she did with them overnight. Sometimes they go to the doctor's offices. And most of the time, they just show up at the very front of the hospital, and they're handed off to a desk clerk in the front of the hospital. When we receive hazardous drugs, according to USP 800, we have to do many things. We have to wear chemo-rated gloves. The drugs must be sealed in impermeable bags. We have to receive them in neutral air flow zone while having a chemo spill kit readily available in case of a spill. Yet, for some reason, it's okay to hand off chemos to the front desk person in a white bag that could be dropped and expose very many people. We're really concerned about the chain of custody. We don't feel like we have good control over the storage or delivery of these products. Next slide, please. This has really affected the standardization of our care. Again, people have already commented on it, but the concentrations of the drugs is a big problem for us, because if it's something that differs from what we're used to seeing, this can create error in the compounding process. Next slide, please. We've actually seen up to 8 patients that have delayed care because the drugs did not come in time. So again, something else that everyone has brought up. Next slide. Everyone's talked about the storage. One of the things we have an issue with is we have a very small chemo room, negative pressure room, and we just don't have room to store each patient's medication if this were to become the way that things are in our storage area. Next slide, please. Everyone, several people have talked about the electronic health record. I just want to point out, we also have to put these in as a non-formulary drug. We have no dose range checking when this is done. We have no allergy checks when this is done. We have no duplicate order checks for when this is done. We lose, as Steve and Rita mentioned, all of our ability to have our standardized order sets that lead to much safer practices for our patients. The other thing is that we have barcode scanning through technology throughout our entire process. We're not able to use it, not even upon administration of these drugs. So we lose another safety net there. Next page. One of the biggest things, and I feel like this hasn't been touched upon, that I have an issue with, is I feel like this is a variation from the prescription. My physicians aren't ordering to dispense oncology vials or vials of medications to another hospital. They're writing an order for an IV administratable drug to be given to a patient over a certain amount of time. So I really feel like these specialty pharmacies are deviating from the actual prescription. The prescription is written to be given intravenously. It's not written to dispense just vials to another pharmacy to compound. Next slide. Because of all these issues that we have encountered, because of our patient safety concerns, we also have stopped accepting any white bagging. We're refusing it now, and it's impacting our members. Some of them have had to finish their last couple rounds of chemo at a different infusion center. Some of them has made the decision not to even go for their last dose, which is very, very sad. But we believe in the high quality and safety of our care for our patients, and we feel that this new process is not aligning with that at all. So really, we'd like the board to consider possibly making the white bagging to support the regulations that you already have and make white bagging illegal, because it breaks so many of them that we're not able to maintain, and it really is not the best solution for our patients. With that, I'd like to end my presentation, and thank you very much for having me.
Thank you. Members, do you have any questions? Okay, thank you, Dr. McGowan. Before we go on to public comment, I wanted to reiterate that there were letters received and submitted for the record. They are in the meeting materials for your review and for public review. Thank you everyone who provided wonderful testimony, presentations, and those of you that provided letters. We certainly have learned quite a bit during this educational opportunity, and I'm sure we're going to have quite a few public comments. I think the best way to do the public comment is, as we stated, that they would have 3 minutes to state their comment. And if it inquires with a question, we'll have to be kind of flexible with the moderator if the question is posed to one of the presenters. So that's something that we'll just have to be a little flexible on, but let's try it and see how it goes.
Maria, should we take a 10-minute break first?
Certainly. Did you want to take a break? We could do that and come back at 5 till.
Makes sense to me. Thank you.
Okay. Thank you. Are we still recording?
Yes, we are.
Great. So I'll take a roll call real quick just to assure everyone's back. Greg Lippy.
Here.
Jake Patel.
Here.
Ricardo Sanchez? Ricardo Sanchez? Debbie Veal?
Here.
Albert Wong? Albert Wong? I think we
Here.
lost him.
Yeah.
Albert,
I'm
we
here.
also didn't record when you returned from the last break. Were you
Yeah,
just a couple minutes late?
I was here. I was here 3 minutes after you guys started.
Okay, thank you. So we'll show that for the record. Ricardo
Yeah.
Sanchez? Ricardo's probably going to join us a couple minutes. We'll just keep a note for him. So as I stated before the break, we're ready for public comment. We will be flexible that if your comment pertains to a question to one of the speakers, to try to accommodate the speaker coming back on so to answer the specific question. But really address your comments to the board members rather than to the speakers, unless it is something that you think that the board would be, I'm trying to think of how to say this, something that would be applicable to the public acknowledgement and education of the subject. I didn't really word that correctly, but I think we're just going to go as we go. Let's go ahead with public comment. Moderator.
This is the moderator. We have opened the Q&A panel. If you'd like to make a public comment, please click on the Q&A icon on your screen. Type "I would like to make a comment" into the Ask field and submit that to all panelists. Our first request for comment comes from Vu Fan. And Vu, your line is unmuted. You will have 3 minutes.
Okay. My colleagues did such an excellent job, so I'm not going to go through the points. First, I'm a physician doing medical oncology. I have a practice of four physicians. We're at LaSalle and Long Beach. I want to share with you a couple of stories with my patient experience. So the first one was a perfect scenario. Nothing went wrong. We was an HMO patient with it took a week for the patient to get authorization for chemotherapy, and then we went to CVS. Of course, my nurse tells me they were put on hold for a couple hours. Got to run around a few times. Finally, it went through. The authorization went through, but the pharmacy had to submitted their claim through the pharmacy benefit rather than the medical benefit, which is basically what drugs are given through the doctor's office, but ran as outpatient pharmacy drug benefit. So that took another week of delay. By the time the drug was delivered to us, it was 3 weeks delay. So that's the perfect scenario where nothing went wrong. Today we had another patient who, after 3 weeks, finally got her medication, but she only got half of her medication. So we had to put our own inventory in, risk of not being reimbursed, in order to give it to the patient. A third patient I have, with again another 3 weeks delay, and patient was so frustrated she paid for her own drug. The fourth patient that we have ended up couldn't afford the drug because it was ran through pharmacy benefit and not through medical benefit, so she had to pay more and she couldn't afford it. The impact, basically, white bagging should be criminalized. This is really a crime against patient care. I am shocked. We feel such a sense of helplessness. I can't believe that this is allowed. So that's the end of my comment.
Thank you, Dr. Fan.
Thanks.
Our next question or comment comes from an individual named Becky Natali. Becky, your line is open. You will have 3 minutes.
Hi, I'm calling, and I've worked in many different avenues. I've worked with systems. I've worked in the hospital. I've worked in physician-based oncology clinics, and I've noticed, I think, over the past few years, just to give you some perspective, that especially the HMOs, I think, to contain costs, have started this practice of doing white bagging. And the white bagging, although I think many of my colleagues have talked about the logistical issues with it to to communicate and get it, it introduces many safety risks, as you're basically getting an auth from an insurance going to the pharmacy that the insurance company has decided upon. That pharmacy then goes through their systems. They transpose the orders accordingly to their side. They contact the patients their way, and then at the end of the day, weeks on, lots of times pass, and for example, a cancer patient, they don't have a lot of time, and they're very sick. And during that time, that passes, when they finally get to their appointment and show up, the day of, you might find out that there has been a miscommunication in the order processes using all these systems from the insurance to the pharmacy to the office. There's been those issues. There's possibility due to back orders or shortages. They were not able to even supply it. So then the day of, you're stuck with a patient who's been waiting to treat their very terminal, very sick disease, and they don't have the medication that they need. It wasn't provided, and you're stuck. Do you undertreat them? And then the other option, I think, when they talk about procurement, you're asking these sites, these pharmacies, to hold all these medications that were dispensed to the patients under their pharmacy benefit, but it's nothing that they can administer because they're in an office doing it under their medical benefit or pharmacy or medical benefit the day of, with these IV medications that require compounding, most of them being hazardous. But we're stuck holding them, and it's the day of, they can't use it. Maybe they're too sick, their dose had to be lowered, maybe it had to be held. We're sometimes stuck holding thousands of dollars of medications that were dispensed to a patient, and when the patient dies or the patient gets discontinued from treatment, we're stuck holding it and ultimately having to waste this medication. This can introduce sometimes the opportunity for fraud, and the medications ending up in different channels because it is this inventory specific to all these patients that's kind of not part of that pharmacy or that office's general inventory. The other problem one day is the drugs come in from multiple different pharmacies.
Becky, this is the moderator.
There's multiple
Time has
brands.
expired.
I'm sorry, I can't hear you.
Time has expired.
I said that on mute. I'm sorry. Thank you, Becky. I'm sorry that your time is up, but we really do appreciate your comments.
Our next comment comes from Melissa Chase. Melissa, your line is open and you will have 3 minutes.
Hi, this is just a sound check. This is Melissa. Can you hear me?
Yes, we can.
My name's Melissa Chase, and I'm the Director of Pharmacy at Valley Children's Hospital, the one standalone hospital in the entire Central Valley of California. I'd like to echo the comments made by our California Medical Association partners and Hospital Association and my peers from the California Children's Hospital Association today. Our experiences here at Valley Children's are very much aligned with those who have spoken today. We did submit a presentation in a written comments and wanted the opportunity today just to make sure that I went through a little bit of our one of many patient impact scenarios. You can look for this in the written comments and in our PowerPoint presentation. But because of our geography and not having any other children's options near us, we've not taken the stance of no white bagging allowed and have had to deal with this directly and have had our patients unfortunately be negatively impacted by these abrupt policy changes for requirements for white bagging. We presented a patient named June who has Crohn's disease and had initially prior authorizations on medical benefits denied for her Remicade. And then through additional back and forth with insurance plans, we were able to get that approved through what we heard today as buy and bill, which means it came from our organization and was infused here for her. And then we were only approved for 2 doses and had to come back for additional prior authorization for this ongoing chronic medication for her. So after the second dose and before we started on the new prior authorization process, and they said that now it needed to be white bagged. And so weeks had gone by through this and additional delays. We did get the second authorization, and at this point in time, we had weeks of delay going back and forth from the insurance. So finally, it went to the specialty pharmacy, and more weeks went by as the specialty pharmacy said they were working on getting the similar prior authorization, but as we heard, it's different from the medical benefits and the pharmacy benefits. They were having some difficulties. There was some confusion over whether or not they would actually supply the medication, who would supply the medication. It was determined actually that a CVS pharmacy in Philadelphia, 2,600 miles away from us, would actually be the pharmacy to dispense this item on a chronic routine basis. That brought into problems with phone calls being 3 hours ahead. Families and pharmacies out here, we all had to take into consideration their business hours.
10 seconds.
And working back and forth. So ultimately, because of this change, we were able to give very great care early on and had significant delays in therapy as the implementation of the required by the insurance white bag specialty pharmacies.
Time has expired.
Thank you, Ms. Chase, for your comments.
Our next comment comes from Warren Fong. Warren, your line is open. You will have 3 minutes.
Thank you. I'm a medical oncologist, and I represent the Medical Oncology Association of Southern California. Just bringing up some new issues. No one likes to say it, but medication errors happen. And the amount of medication errors increase by anonymity and the number of hands touching the prescription. In the office, the nurse knows the patient, knows the physicians, knows the treatment plan, and mixes drugs and gives it to the patient. When you send it off to a pharmacy off-site, the person who mixes it has no idea whether he's given a weight-based medication to a 300-pound man or a 75-pound woman. The second thing is contamination. The risk of contamination increases with time. A little contamination given to a patient immediately probably won't have any effect. But you leave it in the car, or as the other person says, strip it from Philadelphia, contamination becomes a very real problem. That's why you don't open up the milk when you bring it home. Another problem is centralization of prescription preparation increases the impact of mishaps. And we all know about New England pharmacy, compounding pharmacy. It affected 14,000 doses, 23 states. Almost 800 people were sickened, over 100 died. You don't get that when things are done locally to that extent. There was also a case in Mississippi where a compounding pharmacist reduced the dose of Taxols to increase his profit, affecting thousands of people. The second is delivery. I know we discussed it, but the point is when you give chemotherapy, you give pre-medications, which could be several, you give several different chemotherapy agents. If one of them is missing, that blows the whole thing. The second thing is access. Despite the insurance companies saying that oncologists are making loads of money, the fact is oncology practices are in financial trouble and are closing because of this. What they don't tell you about is the uncompensated cost. We can't just receive their chemotherapy and open up in our backyard and give it to the patient. We have to have specialized equipment. We have specialized nurses, and that's not compensated when we get it white bagged. The second thing is higher costs. I know the insurance person talked about cost, but that's his cost. The insurance company's cost. Kind of neglects to talk about everybody's costs, the true cost of healthcare. And while this system saves them money because of vertical integration, where they own the pharmacy benefit manager, they own the specialty pharmacy, with this system, they can increase their profits. They don't tell you about is it increase the whole system. And I think everybody who's come on and testified has told you there's increased administrative costs, problems, not borne by the insurance companies, but borne by everybody else. Increases overall healthcare costs. Thank you.
Thank you, Dr. Fong.
Our next commenter is Chad Morton. Chad, your line is open. You will have 30 minutes. Chad Morton, can you hear us?
I think Mr. Morton's question is in the chat.
So this is, as a chair, I just needed to address Dr. Morton that his comments in the chat are not part of the record, that if he wants to verbally state something at this time, the chat is not for public record. That's just to acknowledge your time. Dr. Morton, are you still on the line?
So this is the moderator. It appears he's trying to communicate, but his audio is having an issue. Would you like me to read the question into the record?
Anne and Eileen, what do you think?
Sure, if we know it's from him and just specify we're reading it into the record and try and get him his audio completed, but at least let's transfer it from the chat to the record.
Okay, so this would be an exception because typically the chat, just for everyone's knowledge, the chat is not meant to communicate. It's just to acknowledge your space for in line for public comment. But since Dr. Morton is having audio problems, we will read his question that he typed in. How do we accommodate compassionate use medications that oftentimes don't come directly from the manufacturer, but from a vendor pharmacy? I'm not quite sure how that deals with specialty medications, white bagging. So I don't know how to interpret his question. Perhaps he can try a phone to get in or another line. We have other public comment, but I'm not sure that his question is related to white bagging unless someone else interprets that differently. Okay.
Okay, our next commenter is Mark Johnston. Mark, your line is open. You will have 3 minutes.
White bagging has been in existence for decades. This is not a new issue. Pharmacies, prescribers, and hospitals have worked together without Board of Pharmacy regulation to increase communication, modify policy, and change operations to make white bagging work for the benefit of patients for decades. Many of today's accounts are initial reactions to sudden third-party change. These products are indeed considered dispensed. The patient, often with assistance from their physician, tells the specialty pharmacy where to ship their dispensed products. The specialty pharmacy communicates and coordinates with a hospital or clinic concerning receipt of the dispensed product. I would argue that CVS specialty shipping pack-out is much more scientific than the packaging that is utilized by the manufacturer when shipping to the wholesaler or the wholesaler shipping to the hospital or clinic, but those two prior steps are rarely the focus of shipping accusations like pharmacy shipping is. Most presenters spoke of cost, profitability, and or third-party billing, which appears to be the source of most stated issues, but is not something the board has statutory authority to address. White bagging begins with pharma manufacturer contracts, which again, I don't believe is within the board's statutory authority. There appears to be a twisting of the law to try to make this a Board of Pharmacy issue, such as using the directly to the patient portion of the definition of dispense, but that limiting clause only refers to prescriber dispensing, not pharmacy dispensing. These are not repackaged drugs, which would be limited to reasonable supplies, etc. I encourage the board and their attorneys to assess board law relevance. Remember what President Lippy verified earlier today. If hospitals accepted the same reimbursement, specialty pharmacy would not be needed. Third-party billing is certainly frustrating for us all and causes many delays that you heard today. If the drug does not get infused, the specialty pharmacy does not get paid. Therefore, specialty pharmacy over-communicates with hospitals, clinics, patients, and physicians, trying to avoid stories like you heard today. Patients being refused treatment from hospitals with 1 dose of chemo remaining, which I think we all can agree is very poor health care. Once profitability and inconvenience is removed from the discussion, I believe that these issues can be resolved with increased communication, which is a two-way street, and modification of inflexible operations. And not what is under Board of Pharmacy control, changes to pharmacy law. Thank you very much.
Thank you, Mr. Johnston.
Maria, I need to say something.
Just 1 minute, Greg. I wanted to give the phone number for for Dr. Morton to be able to dial in. It is 1-415-655-0001, and the access code is 187-928-4930. It is also posted on the board's website. Thank you. Go ahead, Greg.
I just wanted to clarify that what I had said was I just asked a question, and my question was if the facilities did not put a markup on it, would that therefore take away the need for white bagging? I did not in any way endorse any point of view as far as for or against white bagging. And I want to make that clear.
Thank you, Mr. Lippy.
Thank you.
We're ready for the next public comment.
Our next comment comes from Sam Martinez. Sam, your line is open. You will have 3 minutes.
Yes, thank you. I just wanted to thank the presenters. They did a great job of addressing many of the issues we all have with white bagging. Just wanted to point out that on the Board of Pharmacy website, it says that serves to protect and promote the health and safety of Californians by pursuing the highest quality of pharmacy care, which I think we all can agree this is not the highest quality of care with white bagging. Inappropriate use of pharmaceuticals, it goes directly against appropriate use of pharmaceuticals with all the zero compounding requirements that the Board of Pharmacy has implemented and required. There's all kinds of costs associated with that, and basically the payers and PBMs would like us to provide this professional service at no cost. So I agree with the example of, going to Walmart and bringing your steak to a restaurant and expecting them to serve it for free. And it's ridiculous. That's all I have to say.
Thank you, Mr. Martinez.
Our next comment comes from Fred Nishioka. And unfortunately, it looks like he has dropped off the call, so we will keep an eye out for him to come back. So our next comment will be Don Holcomb. Don, your line is unmuted. You will have 2 minutes.
Hello. Is it 2 minutes or 3 minutes?
3 minutes will be your time limit for your comment, please.
Thank you. I am speaking from on behalf of the Medical Oncology Association of Southern California. Our members include hospitals and healthcare systems of all sizes, as well as private medical groups and practices who provide cancer services in Southern California. We will be submitting more detail on these talking points at the end of the night. Hopefully, they can still be arrived in time for the record entering into the record. Some of the highlights we'd like to comment is that white bagging is not commonplace across the country, and if it is forced in California, it will be in violation of California law. The Health and Safety Code for Healthcare Service Plans, Article 5, Standards 1367.22, Section C, states that this section shall not be construed to restrict or impair the application of any other provision of this chapter, including but not limited to Section 1367, which includes among its requirements that plans purchase services in a manner providing continuity of care and demonstrate that medical decisions are rendered by qualified medical providers unhindered by fiscal or administrative management. If the health plans or their contracted specialty pharmacies try to mandate white bagging for qualified medical providers, they will be in fact hindering the medical decisions for sourcing of the drugs that they use for patient treatment, and thus they'll be violating state law. White bagging adversely affects qualified medical providers, putting their patients and their medical license at risk. And it also endangers patients in ways that do not happen when medical providers acquire the treatments themselves for patients. White bagging does create needless waste and increases costs in the healthcare delivery system. And white bagging mandates also violate California patient steering laws. The Health and Safety Code, Part 1.9, Medical Referral Services states that no person, firm, partnership, association, or corporation, etc., shall for profit refer or recommend a person to a physician, hospital, or dispensary for any form of medical care or treatment of any ailment or condition. Whether or not an insurance company owns a designated specialty pharmacy, and most do, it is likely that there will be a financial gain to them for mandating that drugs are white bagged to physicians from that pharmacy, which would run violation of California patient steering laws. As I said, we have far more details available in the talking points that we will be emailing to you this evening. Thank you for your time.
Thank you. Can you repeat that regulation citation? I wanted to write that down.
Oh, for the California patient steering laws, HSC Division 1, Administration of Public Health, 135 to 1179.102, Part 1.9, Medical Referral Services, 334 to 445.
334.
We have that reference. We have that reference. We'll be sending it to you.
Thank you.
And this is the moderator. Just to confirm, Fred Nishioka had indicated that he was withdrawing his need to make a comment as others had already presented the same point. And Mr. Chad Morton is now on. I'm going to try and open his microphone again. Chad, your line is unmuted. Can you hear us? Can we hear you? Still no audio. Mr. Morton, if you've called in on your cell phone, you could be showing up as a phone number instead of a name. If you could type your phone number that you're calling from into the Q&A panel so I can locate you if that is the situation. And Chad, is this you?
Hello, can you hear me?
Hello, can you hear me? We can hear you, thank you.
Oh, hallelujah. Thank you so much.
Okay, Dr. Becky, you have your microphone on both, so we're hearing you stereo.
Yep. So I only have one microphone. Hey, I'll go ahead and take somebody else. I'll just listen in. Thank you.
We needed your question. Go ahead and try. We'll do our best to answer your question.
Okay, thank you. That sounds much better. This process of white bagging is obviously a pain, as everyone has said, but I just want to make sure that a similar process exists with compassionate use meds. This is a system that exists for patients who are able to get essentially free drug from a manufacturer, and it is sent to a infusion pharmacy as a white bag as well. This process is used for obviously financial reasons. Patient is unable to afford the cost of their medication. It's only available to private pay insurance patients. I don't think you can do it for Medicare or Medi-Cal patients. But we have experience where compassionate use meds that come from Pfizer, Genentech, are sent. The manufacturer has a vendor relationship with a specialty pharmacy, and then the specialty pharmacy sends it directly to us in the infusion center. And it's very, very confusing on how to separate out white bagging from an insurance company versus a compassionate use med. So that's what I just want the board and listeners to be aware of. This is a very complex process.
Thank you, Dr. Morton. Moderator, do we have any other comments?
That is all the comments I see at this time.
Great, thank you. We can close the public comment.
It is closed.
Okay. On behalf of the entire committee, I would like to thank everyone for your participation in our meeting today. I think we all found it very informative. There certainly are issues with patient access to specialty medications and safety. The issues between payers and providers are complex. We will need to consider what are the opportunities available to the board to address white bagging from after discussion with our board staff and legal counsel. I do encourage you all to attend the board meetings in April. This committee will provide a summary of this informational meeting at that board meeting, and following that meeting, any additional activity by the board will be announced. Thank you all for your participation. It was a long afternoon, but very informative, and I wish you a good afternoon. Thank you.